Everybody's going to have a little bit of time for.
Yeah, so we have to, we can start.
Yeah, we'll
We can
moderate and then
rehearsal.
we'll moderate and
Yeah.
so let's open it like this.
So I'm not audible. I'm not audible. Again, it's not working.
Is it?
Sure? Sure. So,
Yeah.
okay.
It's just not working here, but it's.
So today we have an eminent faculty and three interviewee with us, and it's my pleasure to introduce them all. So first of all, I want to introduce Dr. George Hidalgo, who is the president of World Federation of Intensive and Critical Care. No, critical care, intensive care.
President-elect of the World Federation of Intensive
No,
and Critical
intensive
Care.
and critical care. Oh, so Dr. George Hidalgo, who is the president-elect of World Federation of Intensive
You
one,
just
one
press
thing
the
I
green
want to
button
say,
when we're
when
ready.
we will answer the question in a short time, that will be more interactive. We can
No,
have
just
more
wanted the chronograph.
experience
So,
on this.
no, no.
Okay.
So,
So I think 3 minutes.
here
is
is.
Mine
It's
will
at
be even
45
shorter,
minutes.
don't
Simply
worry.
start.
Yes,
And then
just
we'll see
answer
it.
1 minute, yeah.
See? Okay, I'm gonna cancel now and just simply press the button. Let me.
Whatever the client asks, we
Huh?
are happy with that.
Sorry?
If the client asks for that, we will do that. Patient asking, JVD, JV Peterson.
JVP. He's taking
That's how they call me.
Okay.
JV Peter. Peter.
All the questions are gonna be. Okay. No, this one is for George,
George.
and this one is for. So I have to say.
We can use some
Peter.
cheat sheets, no? I made a lot of points.
Yeah, it's fine. I just don't want to forget that.
Yep. No, you have to introduce yourself, definitely.
Perfect.
World Federation General Secretary. Me, Dr. Javier Fernandez,
Yes.
who is the General Secretary of World Federation Intensive Care, and recently
Right.
I'm working in here.
Yes,
and
I had to
you
introduce
have to
myself.
say,
Yes.
of course.
Yeah, I have to introduce myself. Yes.
Can you ask RCM one call? He's not? Huh? Okay, so no problem. I think we should start at time, in time, because everyone will see us in live, you know.
Yeah.
So
Let's
for that
start,
reason, they are not. So is it 1 p.m. already?
No.
I'm very
No.
tight.
Okay. Okay.
We got 5 minutes.
Sorry?
We got time for maybe a drink, maybe a coffee. I'm just
Yeah,
kidding.
coffee. किसको बोलूं? ICCM ऑफिस का कोई है? कॉफी लगेगा सबको.
Sure. Can you hear me well now? It's, we can talk about the weather. We can also talk about movies. It's up to you guys. Sports. No? Let me know when you talk more or not. I can talk a lot. My wife says that.
When it's live, you have to say it's live now.
And then we'll make jokes.
We will make it. Yeah.
Is he so cold?
लाइव में क्या प्रॉब्लम है? लाइव तो हर दिन ही हो रहा है. ओह, अच्छा.
So we're transmitting live here in the middle of a soccer game. Oh my God, this is a tremendous game.
Yes.
We see Lopa just running on the band now. It's getting close to score. Oh my God. Passes the ball to George. George is going to hit Assisi. Assisi, please. And then
Score the goal.
Ah, Jamie Peter.
No.
They'll get shocked.
Go, yeah.
It will be like that at the night of the fashion parade, like,
Yes.
oh my God, what is doing? All are there. So in the TV studios, they all are heroes.
Yes. Ah, you are
See?
recorded.
Yes.
Wow.
You're being hurt.
Assisi scored the goal.
Excellent. But who will arrange the coffee?
Oh.
Yeah, we. No problem.
to the count of three. 3, 2, 1. Welcome everybody, and thank you for coming to this live broadcast session for Criticare 2023. And we're here to discuss today a very interesting topic. I am Dr. Javier Perez Fernandez. I'm from Miami, USA, and I'm also the Secretary General of the World Federation of Intensive and Critical Care. And with me is Professor Sheena Lopa, who is also a fantastic presenter and definitely cuter than me, and is going to talk to the guests that we have today, a fantastic group of professors that will discuss the topic of research, and in particular the difference between research in adequate resource countries versus under-reserved or underserved countries, resource countries. And in this case, Dr. Lopa is, please, welcome.
Thank you, everyone, and thank you to Javier for your kind introduction. So, what I want to say that is this is the first ever concept in the Criticare, and in Criticare 23 we have arranged the Criticare TV studio concept. So this is a great honor for me to introduce such eminent interviewee with me. So I want to introduce first of all Professor George Hidalgo, who is the President-elect of World Federation of Intensive and Critical Care. And also he is the head of the Critical Care and COVID-19 Belize Health Partners, Belize, and his area of interest is sepsis, ARDS, obstetric critical care. So welcome, George Hidalgo. We also have with us Dr. Adil Al-Sisi, who is the CMO Prime Healthcare Group, and he is the head of the ICU department in the Prime Hospital. He is also affiliated to Cairo University, Egypt, and he is interest of area is sepsis, shock states, mechanical ventilation. So welcome, Dr. Adil Al-Sisi.
Welcome, Dr. Lopa.
And this is an honor for me to introduce Dr. J.V. Peter sir, who is doing research for more than 30 years in India and abroad. And sir is the professor of critical care medicine in Christian Medical College, Vellore, and his area of interest is tropical infections and toxicology. So welcome you, sir, in the TV studio. And I want to introduce Dr. Srinivas Samavedam, who is an excellent speaker and also a dynamic intensivist, and he is the chief intensivist of Hyderabad TX hospitals. His area of interest is neurocritical care, quality and safety in ICU, artificial intelligence, and also machine learning. And he has done lots of research also, and he has interest in obstetric critical care. So welcome, Dr. Srinivas Samavedam.
Thank you.
So over to you, Dr. Javier.
Thank you so much, Dr. Lopa. And to all of our guests, we're going to try to make this interactive, so please feel free to interject any one of the comments that they definitely is going to be asked to one of you particularly, but please feel free to introduce some other topics as well. The first question that we have here, in order to start a little bit the dialogue, is for Dr. Hidalgo. And Dr. Hidalgo, you have obviously a very prominent position in the World Federation, and you'll expose yourself to different areas of let's say, development and research in particular. So what are the unique challenges that are faced by, when we talk about research, by resource-limited countries versus non-limited countries? What do you think those difficulties are, those obstacles or roadblocks are, from your experience?
Well, first of all, I want to thank you, ISCCM, for the invitation, and of course, thank you, Dr. Javier, for the question. And of course, when we talk about resource-limited country, there are many things that we can say, especially in the field of research. And one of the things could be related with technology. Of course, one of the lack of resources, the lack of equipment, the financial resources to acquire that equipment, but also that goes hand in hand with the human resources as well. I mean that's definitely, it can impact directly outcomes and also the way how research can be conducted in the resource-limited countries. One of the things also is access to the data collection type of systems, because that also it will impact the way how we can collect the information. I mean that it's a lot of things that we can do and also that we can plan in terms of that. But just in a short note, we can say that those are the three aspects we can focus more. One, the human resources. Second, the access to equipment. And the third one could be the electronic data systems to collect the information.
So, thank you, Dr. George. So now I want to ask Dr. Adil Al-Sisi, do you have your comment, what George said? So you want to add something on it?
First of all, also I would like to thank and congratulate Indian Society of Critical Care Medicine for conducting such a wonderful and successful event, including all updated topics around the ICUs and critical care medicine. In regards to our topic today, we will talk about the difficulties between the resource limited and resource rich countries. As Dr. Hidalgo said, very, very important because it is a contributing factor which result in a successful research work. Very, very important we have a government of the country and the health local health authority of the countries along with the healthcare facility, along the public general public awareness itself to participate, to stand to understand exactly what we are going to get accurate result, helping us in the future to get accurate things, because medicine is changing by time. And if we are talking about 10 years, 20 years back, if you are talking today, maybe after 5 to 10 minutes, a lot of things change based on the research and the study work. If this study work done properly and accurately, with these all contributing factors together, hand by hand, we can reach to the optimal result as well.
Let me ask Dr. J.V. Peter, Professor J.V. Peter, you have a lot of experience in research, and one of the things that I think differ from one country to another is outcomes. For really what outcomes should be in research in the United States, to say something, are those the same that it should be in a country such as India?
Thank you for the question, and thank you for the opportunity to be a part of this very important session. I just want to step back a little bit to talk about this whole concept of generalizability. You touched on this. Data coming from the US may not be relevant to developing countries. And so it is for resource limited settings to provide data that is relevant to other resource limited settings. So that's one key aspect that we need to look at. Now, are we really resource poor? I don't think so. There are resource rich situations that we are privileged with. A lot of patients, a lot of intensivists from across the globe who bring in diversity. So I think though we are resource limited in certain things, we are also resource rich. Now, coming to the outcomes, I think the hard outcomes that are generally ascribed to critical care research may not be applicable to developing countries. Because, for example, a person who comes out of a critical illness who has got physical disability is still not a favorable outcome for that family. It may be favorable for, in one sense, but not favorable from a societal point of view. So I think the outcomes in developing countries should be more favorable and unfavorable, much like what the neurologists do. Neurological outcomes that are favorable and unfavorable. Death is also unfavorable. So I think these need to be clubbed together in resource-limited settings in terms of outcomes.
Thank you so much.
So now I want to ask Dr. Srinivas that, yes, sir have beautifully described about the outcome. So we are country from India or like Bangladesh, we are working. So do you want to add something that something make it more easier, or we want to do it like for the outcome?
Yeah, so as Dr. Peter and others also have alluded to before, the softer outcomes in intensive care, like the length of stay in the hospital, the length of stay in the intensive care unit, become more relevant in our context because of several aspects, especially from the utilization ratio of our intensive care beds. So, from an organizational perspective as well as from patient's perspective, a length of stay related assessment of outcomes for the interventions we do may be a more effective and a more implementable outcome than the well accepted 30, 28 day, 90 day and 1 year mortality. So that's something where I think we can start from looking at softer outcomes.
Thank you,
If I
Srinivas.
can add something,
Yes, sure.
yes. Well, it's very complex when we talk about outcomes, especially in a very heterogeneous population that we need to manage in ICU. Normally, when we talk about outcomes, we talk about mortality. But as you know, the clinical trials those days, they say, why we don't change the endpoints of the clinical trials? Probably we need to be more specific. If, like, just to put an example, if we are talking about removal cytokine type of technology, probably we can say, let's add as an endpoint what this technology is offering. This technology is offering just the removal of cytokines, but what happened with other inflammatory mediators. I mean that in the type of population we handle in ICU, outcomes is a very complex type of work.
Okay. So next question to Dr. J.V. Peter, sir. That is the how do differences in infrastructure and technology impact the quality and outcomes of research limited, critical care research in research limited and research rich countries?
I'll talk about both infrastructure and technology. Start with technology. I think technology aids research, but it's not the end, the most important aspect of research, because there are technological limitations which can also be used as an advantage to create pathways and explore cost-effective therapies. When you're really stretched in a health system, limitations of technology may help you innovate and come up with new techniques and technologies that may be beneficial. And we saw that very much in the COVID pandemic, where there was so much of innovations which came up because there was limitations in technology. But what is different in developing countries is also the infrastructure. I would use the term heterogeneity, or a lot of variability in critical care practice in developing countries, and that actually creates a huge problem in terms of research and in terms of generalizability of the research that is generated from a particular setting. We have private and general, we have different case mix, we have paying patients, non-paying patients, we have ability to pay, which may also be an important determinant in research. So this creates a lot of challenges for us in terms of infrastructure and outcomes in research. Now, when we look at outcomes in research, we did talk about hard and soft outcomes. Just to clarify one point, the best or a favorable outcome is alive and getting back to a reasonable quality of life. So rather than dead and alive, person who's alive but able to get back to full meaningful activity would be favorable, and the rest may be clubbed under unfavorable. Now, going on quickly to the quality of research, I think what matters more is asking the right questions. I'm reminded of a quote which says, "This is definitely the answer, says the computer." And I've checked it twice. The problem was you didn't know what you were asking, and that's why you got the answer. So I think quite often we are quite confused as to posing what the right question is. I think that is where we should focus on in resource limited settings. The second aspect that we need to focus on is the use of good statistical tools. Again, I'm reminded of a quote by R.A. Fisher, who says that to consult a statistician after the experiment is over is to ask him to conduct a post-mortem examination. He may be able to tell you what the experiment died of. So I think there are several of these aspects that need to be looked at in a resource limited setting to be able to enhance the quality of research, which will certainly be relevant to many other developing countries. It's not that we can't provide answers to problems of the developed countries, but I think the relevance will be more to other developing countries.
Professor, thank you so much for such a kind answer. And I'm going to take advantage of that and ask the right question then to Dr. Professor Hidalgo. As you're, again, representing the World Federation, how can we make this gap closer between countries with low resources or the availability of resources limited versus those who don't have that? Is there any role for transnational organizations such as the World Federation?
Well, I think that's a very good question, and one of the plans that we have for the next couple of years, and probably I say we can add for the next 2 to 4 years, is to essentially increase the collaboration. I mean that, as you will say, there are, and we were discussing right here, there are countries that probably they don't have the similar access to resources, but the reason why we are here together, we are here, U.S., Bangladesh, Abu Dhabi, we have India, all of us united is that I think so that is exactly what we want to have in the World Federation. We want to establish alliances, we need to establish networking and open possibilities that for many countries that otherwise should be very difficult for them to have and be part of research programs.
Okay, so thank you very much, George, because we expect from you that you are taking the charge of the president of World Federation. So we hope that you can do something in a global thinking of us. Basically, what I want to focus in our resource limited setup. So do you want to add anything with Professor Hidalgo, Dr. Adil Al-Sisi on it?
This is very important topic when we are talking about successful research work. It will not come until collaborative teamwork is there. We can give a real model or real example for last couple of years. We have from European Society of Intensive Care Medicine a EuroPac 2 study done in 333 ICU departments, including 52 countries. These 52 countries divided into resource limited and resource rich countries, and the study conducted in 2,600 for patients admitted in ICU who acquired hospital acquired bloodstream infection. What about the epidemiology and outcome? All these patients, there was unified Excel sheet and how much is the access to the system for all of us. So all over across the globe and all over the world, we are all on the same page, on the same track. So we know exactly what we are doing. So we are giving the standards and the unified protocol, which helping us to stand on the same page. This will minimize the gap between us, what we are doing exactly, and even any region or any country. After that, they can do their local, because we would like to, all of us know when we are doing a research work, there is a genetic predisposition in this area, in this region, but we are taking the data at the time from the system, how we get it in the system, all this together as a collaborative teamwork, along with the awareness of the patient in this area or the public in this area, all together day by day, I think will minimize this gap, and we can reach later to be one team, one family for this research work.
Well, before we move into the next question, which actually is directed to Professor Assisi as well, I would like to create a little bit of polemic and create a little bit of debate here between Professor Peters, J.B. Peter, and Professor Srinivas. And Professor Srinivas, you mentioned that your area of interest is technologically advanced.
Yeah.
You say that, right?
Yes.
And right on that.
Yes.
Okay. So let me ask you, what's the role of technology to close that gap? Because Professor J. Peter said before, well, maybe it's not such as technology as it is human, or the right questions, right, as well, the human factor, let's put it that way. What is your opinion about that?
Yeah, so we are sitting at the conference of the Indian Society of Critical Care Medicine, and during the next 3 days you would hear a lot of speakers and others deliberate about meta-analysis and randomized controlled trials. Now that is considered as the apex of the pyramid of evidence-based medicine. But if you look at the entire cohort of patients who are actually affected by a disease, what a randomized controlled trial or a meta-analysis actually looks at is only maybe a pinhead of the entire database. If you actually apply a machine learning platform or an artificial intelligence platform to the common problems we see in India or in tropical countries or in developing countries, like a thrombocytopenia coming into the intensive care, and you put in all the data that the country can produce, like 1,000,000 data sets, the decision making process, the information you get, and the algorithm tree that you can develop would be much more robust than what a meta-analysis or a randomized control trial can do. And you would probably be doing a more scientific way of executing your practice than just relying on 10,000 or 20,000 patients when you look at data sets of a 1,000,000 cohort. So we are poor in certain resources, but I think developing countries and some of these countries are very rich in information technology thought process. So if you can augment, international societies collaborate and augment this capability of the resource limited countries which have the database and the know-how, I think together we can make the treatment algorithms more robust and more effective.
Fantastic.
Will I get a chance to rebut?
Yes, of course.
I completely echo what Dr. Srinivas has said. I am not against AI or big data analytics. But I want to make a distinction between technology limited to, high-end invasive monitoring or very high-end equipment to manage your patients versus data and data analytics. I think India is strong in computer and IT, so certainly endorse that part of it.
Fantastic. Well, thanks so much, and thanks for the clarification. Let's move to a different topic. Let's talk a little bit about ethics in research, a very hot topic, of course. But the question is ethical research, or when we look at ethic principles in research, are those the same when applied to low research countries versus high research countries? And to answer that, Professor Assisi, so what do you think about it?
Very important point, Dr. Javier. For this point, for the ethical consideration, always there is ethical committee, and these things are very greatly between resource limited and resource rich countries. For example, in resource limited countries, we might face a limited access for the informed consent processes and how to protect for human rights and awareness of the general public in such countries, and also for the acceptance for this medical research work. These things we are still facing till nowadays, until we reach to the point that the knowledge more and more and awareness more and more in such regions or countries will help the research work more and more. In addition, we have also the limited availability of health care resources, because there will be procedures or treatment will be given to a particular group of patients who will be studied at the time. So the decision will be ethically, shall we give or not? For example, some patient not in belief to have any blood transfusion till nowadays. You are talking about this point. This is related to fixed belief sometimes. But if these things to give more and more awareness to the community with the help of the governments and the local health authority, I think will put those countries with the availability definitely of the equipments and some finance go toward the research work in parallel to the providing the clinical services to the patient. The research work is very, very important to stand exactly in such countries or geographic regions. What is the epidemiology incidence of certain diseases related to, again, to the genetic predisposition, and what medicine or lines of treatment might help him, all of them in the future.
Very good. But let me throw the hot potato here. Right, and let me look at you, Professor J.B. Peter, because I think this is very important to clarify for the audience and to clarify for the rest of the world as well. And we're here on the Indian Society of Critical Care Medicine annual meeting. I think this is a fantastic venue, fantastic meeting, and I think, as you said, India has a very, very very much expertise in many aspects. But we want to clarify something. What is your opinion regarding they say somewhere that low-income, low-resource countries have very laxative protocols for research, and the control is not such as good, and so the results of those studies should not be taken into account. What's your opinion? And then briefly, we're going to ask the rest of the audience here what is their opinion as well.
So excellent question, and I'm very, very clear that the end, which is the answer to a question, cannot justify the means. Humans are humans wherever they are located, whichever part of the globe, and I think it's very important that we fulfill every ethical norm for research. I'm very happy that the National Medical Council and the Indian government has taken very serious note of this, that any randomized trial has to go through a very, very rigorous process of ethical approval and data safety monitoring by external groups. So I think this is coming in a big way. But having said that, there are many good trials where there's clinical equipoise, where a poorer patient who may not have access to any treatment may be able to access some good quality treatment. So that's my position on this, that the ethics cannot be compromised even in a resource limited setting, although there are tendencies for that to happen in certain countries.
Yes, and I completely agree with your statement and state that humans are the same everywhere. No, we cannot say, okay, we are going to act or trying to conduct this particular study in a country because probably it's going to be more flexible versus doing it in another country with different type of regulation. I think so those days the safety and the regulation system have evolved in a way that one of the most important things is trying to protect the right of the patients.
Okay, thank you. So, but next question is for the president-elect of World Federation. This is a very important question I want to ask. That is how does the availability of funding for critical care research vary between the resource limited and resource rich countries, and what impact does this have on the development and implementation of new treatments and interventions?
That is a very interesting and also a difficult question. Of course, the access of funding to do research varies with country to country. No, we cannot compare what access to grants have countries like the U.S., no, where they have more funding for research versus access to funding to low-income countries. Definitely, that's have an impact on that. However, as Dr. Peterson well said, the research and the access and the different population we have, it changed dramatically in the last years. But of course, unfortunately, the funding plays an important role. And the main idea, as I mentioned in the beginning, is to trying to establish collaboration with societies, also trying to establish collaboration with organizations that can facilitate this funding and make the research possible in the low-income countries.
So let me interject some of the other presents here. Professor Sisi first. How do you see the funding for research between, or the difference between private funding versus institutional funding or public funding, right?
Yes.
Is there a difference? Do you have experience on that? What do you think we should ask for?
Yes. Thank you, Dr. Javier. This is very important if we are talking about institutional or governmental funding for the research work, because we ensure that this funding will be well distributed to conduct a successful research work. Sometimes the private sector, they are planning to go to certain way or certain definite outcome from the beginning. Sometimes, we are not saying all times, but I believe with something which is more institutional, more governmental, more consensus for all, to help us with the healthcare facilities along with the general public to have such kind of research in this community to reach to the best level of result and also accurate result. So I believe, this is my from my point of view, that these things need more supervision from higher committees, which you see exactly where these funds to be well distributed and to get at the end the best result.
Perfect. But let me go now to Professor J.B. Peters, and let me ask you one more thing. No, let me ask you something different. So, is limiting private funding bad for outcomes? Because you like the outcomes. So tell me, is it bad for outcomes? And what I mean with that is, we all discuss, and I'm sure the audience have the question there. When we look into the private industry moving research, we find outcomes. As an example, you know, antibiotics, vaccines. However, when we look into the public funding for diseases that don't have the same attention or interest for the private industry, the outcomes are not necessarily as fast. What's wrong, what's right?
Let me step back to tell you what funding is available in India.
Okay.
I think it's very important for us to know what are the possible sources of funding for research. I think at the bottommost part of the pyramid is institutional funding. And this is a problem again because we have three types of organizations in India: the for-profits, the not-for-profits, and the government. I think in the for-profits, there is some challenge in getting funding, although many for-profit organizations are now focusing a lot on research. Government also has some sort of funding, but the not-for-profits, like our own institution, devotes a lot of funds for research. So that's the first level, and you can do some good quality research with such funding. The second is grant organizations. There are several grant organizations that you can appeal to, and if the research question is good, it's going to be making a difference to our patients, certainly they will fund. The third level is the government funding, which is limited, but there are several organizations in India, the ICMR, the Department of Science and Technology, Department of Biotechnology, all of whom give large grants for research. But unfortunately, most of these grants go for basic sciences research than critical care research. So that is a problem, but that is changing. The COVID has really, opened the eyes to say, critical care also needs some funding for research. The last is the funding from the industry. I'm very cautious with that. And there are lots of checks and balances that need to be put in place, because any industry that funds research funds it with a motive that they want to make sure it works. And if you torture the data hard enough and long enough, it'll confess to anything. I think we need to keep that in mind when we are seeking funds from industry.
And that actually opens the question for Dr. Srinivas, which is, who owns the data? Because that's a concern for most of the people, participants on trials, even some of us that we promote research trial. Who owns the data, especially with the technology being able to transfer this data?
Yeah, so that's always a moot point and a point of concern, that who owns the raw data, because as Dr. Peter said, if you torture data, you could get the result you want at the end of the day. So my perspective is, either a national regulatory agency owns the data and the access to the data is sorely limited, or a professional society or a group of societies like the intensive care societies, if they actually initiate and fund the research, it should be in the hands of the professionals who run the data, rather than from the principal funding source, which could be industry.
Fantastic. So thank you, and let's change the topic, but let's continue with you, if you don't mind.
Okay.
Let's talk a little bit about data, and let's talk about personalization.
Yeah.
Let's talk about what is the role in personalization, what's the big data role on cultural differences and other differences that might apply to research, but other aspects of medicine as well. So what is the role on that? And let's take that as our last topic.
So yeah, the cultural and other differences are intrinsic to a multi-pronged society like ours. If you give an example, if I may take an example from cardiology and intensive care practice of using oral anticoagulants in patients who have arrhythmias. In our own Indian cohort of patients, there are several subsets who respond differently to the same dose of a warfarin or your novel oral anticoagulants. We are all Indians. We all come from the same geographic sublocation, but our response to the same dose of oral anticoagulants is different. Now, why does that happen? So if you can actually analyze all the patients across the country, a billion of us, and then see what subtle differences in our phenotype exist, we could be able to have an algorithm and say, if this is the phenotype of the patient who has atrial fibrillation, this is the dose of warfarin you could use on this patient. So that kind of data would actually help us in making our prescription for potentially dangerous medications like amiodarone, like oral anticoagulants, more safer for patients. So in a resource limited setting like ours, where access to immediate healthcare attention may be delayed, if you are going to prescribe something which is potentially dangerous, if you can make a more educated decision based on artificial intelligence and big data analytics, I think the society would benefit a lot rather than a prescribed textbook driven prescription.
Fantastic. Professor JB, Peter, are research results applicable to all? Are you, or do you believe in one size fits all?
Certainly not. I think the answer was very obvious. I just want to take the example of oncology. I think they are far ahead in terms of personalized medicine, and there is a lot of talk now in intensive care also to prescribe personalized critical care. And I want to take on from what Dr. Srinivas said. I think big data analytics may be the key to identifying and stratifying people based on who may respond or not respond. In that context, I think in India we have the ability to research on complex topics like severe ARDS, which is very frequent because patients come very late, looking at mechanisms that may contribute to the evolution or the pathogenesis of ARDS, or what might or might not work. So I think we are uniquely placed in terms of numbers and in terms of the disease profile to give some answers to the whole world on certain aspects of critical care.
Fantastic.
Although culturally different.
Fantastic. Professor Assisi, what do you think about cultural differences applied to the patient's cohort? So when choosing the patient cohort, cultural limitations, put it that way, how does affect the research itself, and what are possible avenues to disimpact that phenomenon?
Yes, very nice, Dr. Khafir. I would like to correlate the social and the cultural of communities, diversity of communities with the ethical part. Ethical part will not touch the human right, definitely will not force anyone to enter in a study. If he's accepted, will do. If not accepted, will not do. This is ethical. But some communities, for example, not in belief to using the machine, ventilator. It means for them, the patient already is died, and the medical team would try to waste time and waste money for this family to get more and more. This is, we can say, social or culture based. Shall we work in this awareness to minimize the gap between the resource limited countries and the resource rich countries? More awareness of the communities and public for this. Ethical is something different, which will not do anything, will not force anyone. This is ethical consideration. Regarding the other things, in order to minimize the gap among across the globe, among these countries, because I believe we are all humankind, and all we have our thoughts and these things. Shall we share the information together? Because we are a small village now. And like a technology, the mobile, when we started to emerge, some people not and believe now everyone in the whole world is using the technology and mobile. So this concept regarding to the cultural and social factors, if we will try to explain, and it started to be something familiar, or we can do it together, I think we can minimize the gap, including more and more countries in the same. But still, if not, we will respect the fixed beliefs and we respect the ethics for each region. This is what I would like to differentiate between the ethical consideration and the social and these things together. Thank you.
Excellent, Dr. Al-Sisi, because these things are very important because cultural and social. So we are end of in the session. So I want to start with George. So can you summarize today's session, like we are going to the conclusion. So you can say about the whole thing what you want to summarize about it.
Well, this is a very interesting discussion, no? And when we talk about research and, of course, the differences between countries, definitely we can spend a day talking to the same. But I think so. At the end, we want to just thanks the Indian society for this important discussion. And I want to take an opportunity to invite you guys to the World Congress of Intensive Care in Istanbul that is going to be held the 26th to the 30th of August. Thank you.
Thanks, Dr. George. So now, final comment from Professor J.V. Peter, sir.
I'm reminded of a quote which says, the scientists of today think deeply rather than clearly. One must be sane to think clearly, but one can think deeply and be quite insane. So my appeal is, as scientists, we should think clearly and also deeply to find answers to the problems that we face.
Okay. Thank you, sir. Final comment from Dr. Srinivas?
Yeah, I think research, especially in the field of critical care, is definitely what's needed to answer unanswered questions. And in this regard, collaboration between the resource limited and the resource rich countries is the only solution. The hypothesis that generates from basic research that happens in the resource rich countries can be extrapolated to clinical research in the volume rich but financially depleted developing countries. Only collaborative research is the answer to definitive challenges which the field of critical care medicine faces.
Thank you, Dr. Srinivas, and I want to take the opportunity to give thanks to everybody, to the organizing team of the ISCCM Criticare 2023, and I want to invite you all also in the World Congress of Intensive and Critical Care in Istanbul in the 26th August, and hopefully this time from our Asian countries they will contribute more, and we are really excited about the event, and I'm very happy to having President-elect and also the General Secretary of World Federation of Intensive and Critical Care. So thank you very much. Thank you all.
Thank you.
Thank you all.
Thank you.
Thank you.
Goodbye.
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 That was,
Finish? Great, great. Thank you.
that was like robotic. दरवाजा इसका मीनिंग है कि दरवाजा
Good afternoon, everyone. We are going to run an interview session today, and I'm very happy to be a part of this session. And with me today is Dr. Lopa, an intensivist from Bangladesh, Dhaka. And we are going to interview 3 experts, very senior experts, famous in intensive care. So over to Lopa.
Okay. Thank you, Dr. Monica, but I think she missed herself to introduce.
Yes.
So she is Dr. Monica Gulati, who is working in Singapore as a consultant and intensivist. So she is also very active in collaboration and also doing research activities and also in lots of talk in Congress. She's an international speaker. So for the first time, first ever TV studio concept in Criticare, and that is in Criticare 2023. So I would like to give thanks to the organizing committee. And this is a great honor for me to have this interview with the famous, eminent interviewee from around the globe. Today we have with us Professor Rickard Ferrer, who is the council member of World Federation of Intensive and Critical Care. He is also the member of Executive Committee of European Society of Intensive Care Medicine, and currently he is the head of the department of Vall d'Hebron University Hospital, Spain. His area of interest is sepsis, severe infections, and ICU design. And also we have with us, we are happy, he is the president of ISCCM, Dr. Jan de Valle, and he is the professor of Ghent University Hospital, Ghent University. And his area of interest is sepsis, antibiotic therapy, PKPD, antimicrobial resistance, and also abdominal catastrophes. I'm so happy to introduce Professor Josh Chacko, sir, who is a very senior, dynamic intensivist, and who is working for last many years from India and also abroad. So, sir is the senior consultant of Narayana Health City, Bangalore, India, and he is actually, his area of interest is ultrasonography and echocardiography, ventilation in refractory hypoxemia, renal replacement therapy, and also evidence-based critical care. So welcoming you all in the TV studio in Criticare 2023. So over to you, Monica.
Hi. So I'm going to ask the first question from Ricard. Hi, Ricard. Can you describe the process you use to identify areas for quality improvement in an ICU setting?
So thank you very much for the introduction, and also thank you very much for this question. So in the ICU, you have to identify which areas you have for improving, and I think the most important area is patient safety. So for that, we are using safety rounds. We are rounding at least one per month with a multidisciplinary team, and detecting those gaps and designing afterwards intervention to improve those gaps. I think this is a simple intervention to monitoring quality and safety of the patients, and that can give you clues for which points you need to improve. Also, of course, it's very important anonymous self-reporting of adverse event in the ICU, because then maybe you're going to do an analysis of the root of the adverse event, and then again in a multidisciplinary discussions you can identify which gap you have for improvement. So safety, I think, is the main concern.
Okay.
But there are others also linked to safety. For example, areas of infection control that I guess most of the ICU are monitoring the rates of healthcare related infections. And also this is important because if you have a network, regional or hospital or national network, you can benchmark and to compare yourself with other hospitals and detect also which areas you need for improvement. And of course, if you have problems with your rates of hospital-acquired infections, you have to monitor other areas that are related to that, like the rate of multi-drug resistance microorganisms, how you are performing with hand hygiene, etc., etc., etc. So again, here there is another area which is very important. Most of the ICUs are monitoring outcome measures, so mortality, length of stay, etc. Again, you can benchmark on that and detect also areas for improvement. But I want to mention in my last comment on that is a part of quality improvement, which is knowledge translation. That means how we introduce new techniques, new devices, or new treatments in the ICU. And in most of the cases, I think it's also a good opportunity to assess the process of care of this specific situation, if this is something new antibiotic or new monitor, to assess this process of care and to check if you can improve with the new technique or the new device or the new treatment, how is this process in your ICU, and try also to improve here.
Okay, so thank you, Dr. Ricard. So I want to ask Dr. Jan
Mhm.
that do you want to add something that how do you ensure the process of this systemic and consistent that actually Ricard also told, and actually that are the areas of care delivery are considered. So you want to add
Yeah.
on it?
Well, I think we have indeed similar processes and techniques in place. What I also find often a very interesting source of information is morbidity and mortality staffs that may be more oriented towards the medical care that is provided, but certainly can be a source of inspiration to improve quality overall. Now, another aspect, and probably an important partner not to forget in the whole story, is the family. And I think we need to not only ask healthcare providers in the ICU where we can improve, but probably also try to involve patients and families. I think they have different priorities. We know from a number of areas that they offer another perspective and a very valuable perspective per se.
Okay, so thank you, Dr. Jain. So I have interest because you people are from the in rich countries, like we have in a resource setup. So Professor Jose Chaco is here. So I want to know from you, sir, because the new methods to how do we are using to gather data, and like from your experience, what thing we are actually facing, and what is the current condition, and what is your comment on it?
Thanks, Lopa, for asking that question. Most hospitals, at least in the corporate setting in India, we do have electronic patient records in which we capture most of the events that indicate quality, and they can very easily be captured. And with this big data, we are able to analyze. At least we are making a beginning in that regard. So it gives us a great opportunity to gather data from across the board and address what are the quality problems that we face and address them appropriately. So we've been doing this for the last couple of years, and I can see that as we move on with the passage of time, it'll become more and more sophisticated, and we'll have much bigger data and better information on which we can act upon.
Okay, thank you, sir.
All right. Thank you for that. I would like to ask actually all the panelists, but I would start with Ian, that how do you engage staff members in a quality intervention in ICU? Like on the ISCCM, antibiotic stewardship is a big thing. You've started a training program as is visible on the ISCCM website. So in your ICU, how do you engage your staff members in antibiotic stewardship program, especially because there are some issues, because this might affect the autonomy of physicians, and some people may perceive it as that may be a strong barrier. And so how do you overcome that? How do you get people on your side?
That is a very important question, and probably one of the key issues when we discuss quality improvement, how to get your staff, get everybody on board, aligned for the same goals. So the first and foremost important step is, I think, to create a culture that is really open for change, where people can freely express themselves and give feedback, no matter whether it's towards a colleague, towards a junior colleague, towards a senior colleague, or towards the professor, the most eminent professor they have in the department. So that is a very important and difficult one, I think. And certainly this will differ from country to country. Trust, I think, is a very important and central word in this as well. People have to trust the whole process and to feel safe when they are engaging in quality improvement programs. So also demonstrating, what the effects of a quality improvement program actually is very important to make people understand, this is not just something we do because somebody likes this, but because this actually makes a difference. And that's a very important aspect. Now, this is more like the theoretical background. What do we do in practice, especially towards involving our nurses? We try to identify champions. We try to identify people who are very interested in a certain field. And for instance, in infection prevention, we would identify a number of nurses who are then actually more knowledgeable than the others, and they act as peers towards their colleagues, and they can easily or more easily convince their co-workers to participate in these quality improvement programs. And as a final comment, if I may, I think support from the hospital administration is instrumental, of course. This is really essential to have support, that everybody is behind a certain quality improvement program, and certainly the concept of improving quality and safety in the ICU.
Okay. So, sir, we all know that in India or like country like Bangladesh, we are also trying to make aware normal people. Normal people means actually the hospital staffs that Dr. Jan was talking about, the nurses and staffs from the ICU. So yes, we are a bit behind and we are working on it, but in limited setup like in India, sir, anything special thing we can do, or like we can, because what I appreciate that they are doing on this stewardship program. So do you think this is the time came that we have to be more aware of this thing?
If I may add?
Yeah, of course.
I think teamwork is also a very important role, and understanding that you're not just an individual working in an ICU with an individual patient, but you're part of a team, whether you're the physiotherapist, whether you're the team cleaning the hospital, whether you're the nurse, whether you're the consultant. You're part of a group, and all your actions should be concerted. That's a more general comment.
Sure, sure. Yeah. And Professor Jose Chaku, sir, you want to say?
Yeah, as already mentioned, it is important to identify people who have a passion for in a particular area, like infection control, for instance, monitoring of adverse events, for instance. So it's important to get people on board who have a real passion for it, get their input, and let them take leadership, take the onus, and lead the team in the particular area that they have a passion for. So we have done this with nursing teaching, for instance, monitoring of critical incidents, other measures of quality control, antibiotic stewardship. So all these can primarily be nurse driven if you have a sufficiently large number of people whom you can motivate, encourage at every step, and get them on board.
Thank you, sir. So, and Professor Ricard, you want to add something on it?
Yes, I echo my colleagues, but I want to maybe add a couple of comments. First one will be that it's very important to involve frontline staff. This is very important, but also to give them responsibility not only about the 2, 3, 4 patients that are taking care. Everyone in the ICU have to have the ICU view. And if everyone has a responsibility or is a referent for any other of the ICU, this is much more better understandable that then your colleague come to you and to talk about antimicrobial shift, because afterwards you will talk to him or to her to talk about renal replacement therapy, because you are the referral of that. So to have every member of the staff to have this ICU view, not only the view of the patients that they are taking care, I think is important. And the other important topic I think is important is to share the success. Yes. Because sometimes could be, you just started an ECMO program and this is the group of superstars in the ICU because they are running the more complex patients, but they are running with the support of the others. So to share this success, I think it's also important to have everyone engaged.
Thank you so much, Ricard. And the last thing is so much less done, sharing the success. And so it would be great if people started doing that. It's a positive thing to do. So coming back to quality improvement intervention, I'll go to Jeanne. Jeanne, you've been, obviously you are a leader in your field, and you've probably done many quality improvement initiatives in the ICU. But is there one of them which was starkly exciting and successful in your eyes, and which you would like to tell your story about in terms of what was the intervention, what you did, and what challenges you faced, and what metrics you used? Thank you.
Thank you, Monica. That's a lot of questions.
Sorry,
that's
yes.
heavily biased. Heavily biased, of course. I would like to focus on antimicrobial stewardship and implementing this. Of course, many of these quality improvement programs is progressive. You start with the first step, and then you take one step at a time, rather than just implementing a whole new concept. So progressively, we've been able to involve our clinical microbiologists, infection prevention, clinical pharmacists to come together on regular occasions throughout the week to discuss antimicrobial use. And at some point, you don't need to do any additional effort anymore. It just flows natural because everybody feels comfortable, everybody agrees on the goals, and at some point in time, a very successful quality improvement program actually requires little, if any, maintenance. And stewardship programs probably one of them. We do, of course, keep track of what we do, monitor our antimicrobial use, look at our resistance patterns, etc., etc. So some maintenance in the background is absolutely very important. But passion, the word has been mentioned before, people who are really motivated and people who also understand the problem behind the quality improvement program is very essential. If you as a group, if the group is not convinced that what they are dealing with is actually a problem, then your quality improvement program will fail for sure.
Okay, thank you, Dr. Jan. So actually now the question is to Dr. Ricard, that how do you measure the effectiveness of quality improvement in interventions in ICU? Because I have actually knowing it, I have the interest about it, but what metrics do you use to track progress and evaluate the impact of quality improvement initiatives on patient outcome and staff satisfaction? So
yes, this is a very good question, but before analyzing how we are going to monitor the intervention, maybe we can discuss a little bit how we design the intervention, because the design of the intervention is the key point. Usually the designs of these interventions are not only multidisciplinary, are multifaceted. You have to go for education, you have to go for training, you have to change sometimes the attitude of your colleagues, sometimes you need to change the structure, or you need to buy a new equipment. So, I mean, the intervention usually is multifaceted. And according to the intervention, you have to design indicators, quality indicators, or indicators of the process. But will be designed according your intervention and should be actionable. We should be able to act in these indicators. If we use indicators that our intervention are not going to be able to change it, why to monitor? And this is going to be not useful. So design indicators of process that are actionable and that are related to intervention, to your intervention. So if not, could be quite frustrating. What type of process indicators we can use? For example, we can use compliance with the protocol. This is useful in antimicrobial stewardship, compliance with the empirical antibiotic protocol, for example, etc. Also, time to intervention is very important because we are dealing with many processes which are time dependent. So time to antibiotics, time to diagnosis, time to any of these interventions we are doing in the ICU, it's very important. And then you have outcome indicators that and they are quite linked, because imagine that you do an intervention and you observe an improvement in outcome, but not an improvement in the process. That means that maybe this is by chance, or this is because you have a different group of patients, or maybe this is because you are improving all the time and this is a secular improvement not related to your intervention. So design a very well designed multifaceted intervention, use indicators that are related to your intervention and are actionable, and then indicators of outcome. And everybody should be linked. The intervention should improve the process and then should improve the outcome. If you have improvements that are not related, then you have to have the suspicion that maybe this intervention is not working as well as you think.
Thank you.
Thank you, Ricard. That was such a wonderful answer, and it basically highlights the depth and introspection which is required when you are designing something. Thank you so much for that. Sustainability, because things start, they finish off. And we see that a lot in many smaller centers, smaller hospitals. People are excited, but it doesn't last. So how do you ensure sustainability? And I'm going to ask that from Jean Duval. How do you ensure sustainability of QIs in the ICU?
Well, one of the ways that we try to make these initiatives sustainable is actually having somebody who's responsible for the whole process. So we have an individual within our department who's actually coordinating all the quality improvement programs, as well as looking for new opportunities, scheduling it, and doing a lot of the practical coordination work. And I think that is a very helpful thing. If as a consultant or as a nurse, if you have to do this on top of all your regular work, then probably you may be overloaded, and quality improvement programs may not be on the top of your list. Now, that being said, measuring the effect is, well, not only the effect, measuring the indicators is very important, and keeping an eye on it. And once you see that indeed maybe a certain quality improvement program is no longer very much adhered to, then it's the time to look at it again and identify the barriers that have been that are there. Has something changed? Is it maybe because, for instance, with the surviving sepsis campaign bundles, that people do not longer like the administration of a certain amount of fluid, and they just don't adhere anymore? Then you have to look at what is in our bundle, and we have to just revise it. So the process then really starts again, identifying the barriers and seeing if it needs adjustment. But having this individual is really a very important asset in our experience.
Okay, so thank you.
Thank
It's
you.
a very, what can I say, it's a lovely answer, because we are on it. We also want the quality improvement in ICU setting. So the question to Dr. Jose Chaco, sir, because how do you address the resistance to change from staff members during quality improvement initiatives in the ICU?
Yeah, it is, I think, most important to make everybody to feel part of the team, particularly perhaps in our culture, in Indian culture. There is a tendency for nursing staff to look up towards the doctors, consultants, etc. They somehow consider themselves not up to that level. So first and most important is to make them feel comfortable, make them feel part of the team, and take onus and responsibility for the patients as much as we do. And then give them responsibility. Make them in charge of any particular area of concern. Let them be responsible. Let them take ownership for the patients and give them additional responsibility while motivating and encouraging them. And then, of course, you can also add incentives in terms of certification, additional training, promotion up the ranks. These can all be motivational factors which will perhaps help improve their outlook towards the whole situation. So that's what we have tried at least. And of course, you keep on meeting as a team every so often, at least once a month, to discuss these issues, to let them voice their concerns if they have any, and address them in a timely fashion. So all those things will definitely help and make it all part of a teamwork that will indeed go a long way.
Okay, so thank you, sir. But this question is to Ricard, but I think, yes, you are not working in a resource limited setting. But how do you prioritize this a quality improvement initiative in the ICU given limited sources and also competing demands?
But I just want to say that I think Europe is pretty big, and
Yeah.
the ISCCM has many resource-limited countries, I would
Yes,
say.
they have.
Not about, but I mean,
He is working in a big hospital,
Yeah,
so I'm
but
asking
yeah.
about that.
Yeah.
actually.
no, but I mean, so this is the definition of economy. All the resources are limited.
Yes.
Always are limited.
Yeah.
So you don't have infinite amount of money, so you have to select which are going to be your priorities. And we were discussing yesterday with Jan about that, about the strategic plans. And I think it's important for an ICU, it's an organization, to have a strategic plan where we go to go in the future, and then we are discussing with the team. I told you that everybody has a responsibility in the ICU, so every year we have a meeting at the beginning of the year, and everyone exposes regarding his responsibilities or her responsibilities, which are their priorities, and we select based in our strategic plans which are the one we are going to prioritize because they are aligned with our strategic plan. Also, I think it's important that to take into account which is the value of each intervention. And it's very important to have families involved in that, because when you design your priorities or you design your strategic plan, to understand the value for patients is important. So sometimes we think that the value is in one place, but the families are telling us that the value maybe will be in another place, maybe more humanizing the ICU or other important topics that I saw that is in the dilemma of this meeting. Two important topics, which is cost effectiveness. We should prioritize interventions that are cost effective, and also feasibility. It's also very important because sometimes feasibility is limited and you have to be aware of that.
Okay, so thank you, Ricard. Actually, we are in a shortage of time, but I know that this is for the first time we are talking on quality improvement interventions in ICU. So before we wrap up, I just want to go for the final comments from everyone. So Dr. Jan Diwale, can you comment your final?
I think quality improvement is very important, and we should put all our efforts into it. For me, the primary issue is creating a culture where everybody feels safe to bring up things, and that's a very important first step towards a quality improvement program, I think.
Thank you, Dr. Vale. Dr. Jose Chaco, and we are ending the session with Dr. Chaco's last comments on this. Thank you.
Yeah, thanks for that. Yeah, so I feel the most important thing in an ICU setting is having a team. You need to have team leaders, and you should work as a team. Teamwork is the most important. It's the key to running a good ICU with good outcomes. And every member of the ICU team, as well as those who are involved from other departments, they should be made to feel comfortable, and you should pursue your quality indicators, apprise them in a regular, timely fashion every couple of weeks or every few months, and strive towards improving those quality indicators, and explore opportunities to improve those indicators with the passage of time. That's most crucial, I feel.
Okay. Thank you, Dr. George Chaco, sir. So now is time we have to finish, but thank you all for joining us in this interesting TV studio of Criticare 2023. And I would like to thank you, the organizing committee, to the Criticare team. And I would like to add one thing, that we are having the World Congress of World Federation of Intensive and Critical Care in the August 26th, and I want to invite you all to join that event. And thank you, Dr. Rika, Dr. Jan Diwale, and Dr. Jose Chaco, and Dr. Monica Gulati. So thank you very much.
Thank you.
Thanks, everyone.
Thank you.
Thank you. Pleasure.
Pleasure.
With us, we have three big leaders of intensive care in India, and to introduce them, they have all been very senior teachers and leaders in controlling ICUs, heading the ICUs. We have Dr. Deepak Govil, who is a Vice Chairman Critical Care Medicine at Medicity Gurgaon. Dr. Shrikant Srinivasan, who is a Consultant and Head at Manipal Hospital, New Delhi. Dr. Sumit Ray, who is the Head of Department Critical Care Medicine and also the Medical Director at Holy Family Hospital, Delhi. So, sir, you all have been very big leaders and you have led the intensive care actually of the country. And my first question to you is, Dr. Deepak Govil, is do you think these leadership skills are what we are born with, or do we acquire it as we go ahead in our
So both things are true. Few people are born leader, but the number is very less. I don't know how to define it, and it like people who are born leader, they come up their own. But again, the majority of us are those people who have gradually groomed to become leader. So it is a self-acquired, and mentorship is also needed some time to become a leader.
Dr. Sumit, what are the inherent leadership qualities?
Well, so leadership can be seen in multiple ways. I don't think there is one model of leadership, and so different people have got to their leadership other than being a student activist. Actually, my leadership training is being a student activist, and that's where I learned to deal and communicate with people, put through my point of view and try to convince people of your point of view. That was my leadership training actually, but learning how to be a leader. But one of the main things for a leader is the ability to take risks, ability to take responsibility, credit to the people in your team, and to delegate work to your team and take responsibility for the failures of your team. These would be the crucial points that you have to do to be a leader.
Perfect. Very truly said, sir. Leadership definitely is not an expertise. It is something which goes on constantly, and you have to acquire it and probably educate yourself, and with the experiences you get it. I come to Dr. Shrikant now. As sir said, it is a huge responsibility of a team as you become a leader. And it is also said that you can't keep everyone happy as a leader. It is better you sell ice cream if you want to do that. So how do you think, how do you manage this human aspects about, kind of keeping everybody happy at the same time but being a good leader as well?
So this is an acquired skill, plus as Dr. Govil said, some people are born with it. So human aspect is a very essential part of the entire leadership program, and that's what is mostly taught in most of the places. So people have different cognitive abilities, right? Some are more skilled than the rest, but the role of the leader is to identify or to understand the team in detail, what one person can do, how much you can develop that person to the best of his or her ability, and try to nurture that skill within them. Try to get them to a platform in which they are at par and they are adding to the team. At this stage, you have to give, as Dr. Sumit has rightly said, you have to give equal amount of credit to all the team members. Try to develop them in such a way that they are all on a common platform and each one doesn't feel let out as compared to the other. There definitely should not be any scope for favoritism or just focusing on specific individuals and neglecting the rest of the team, because end of the day, it has to be a positive kind of a interference, if you can say, where you all work together towards a common goal and your vibes are sort of magnified as a leader, which you are progressing onto your team. Anybody who is sort of out of the sync with the other of the team members will sort of, the team will not move forward the way you want it to move. So that there's a strong cognitive ability which you have to recognize what the person is capable of, and there is an emotional capacity. You need to understand what that person wants from that being a part of the team member, how you can nurture that person to get to that kind of a level, and you should also coach them in such a way that they go on to become kind of leaders themselves in the future. So everybody wants something for themselves. End of the day, what's there in it for me? That is the basic question which every team member feels like asking. And everybody has different abilities. So you have to identify what the person is capable of and delegate responsibilities in such a way that that person is able to execute it effectively.
Perfect. So we are going to have the future leadership. But before going ahead, I would like to ask a past leader. Dr. Govil was the past president of ISCCM. Sir, beyond the human aspects, what other skills do you think are important for the leadership, from the leadership?
So biggest thing is the human aspect, which Dr. Shrikant has already said. Then Beyond that, if we go, then you need a strong administrative skills to become a successful leader, because you have to do the administration of a big number of people, long list of the people, and unless you are a good administrator, it is very difficult sometimes to manage everybody. You should be very strict, little strict as well, should be little blunt as well. If you try to please everybody, things are not moving forward, and then the team may fall off, because you are trying to. So, leader should have guts to tell right and wrong in the face of the team as well.
The sense of fair play is very important for a leader, that you should give the impression of being fair. Fairness does not mean that you do not discipline, or you do not take punitive action to a certain extent, the carrot and stick to a certain extent, but the person who you take some degree of punitive action should also feel that it has been taken in fairness. The sense of fair play, I think, is my personal is very, very important. Fair play, that favoritism, as he said, and fair play. I mean, favoritism shouldn't be there, and the sense of fair play is very, very important.
And transparency.
Yeah.
Perfect, sir. So what we are talking about, Dr. Sumit, is about multitasking sort of thing, like multitasking and the time management.
Yeah, that's a difficult one. So yes, and that's the other thing that I wanted to. I mean, when you ask about multitasking, actually, I mean, sometimes we stereotype people, but women are much better multitaskers than men. But still, there are less women in leadership positions in critical care and in many other things, because the fact is that there has been a kind of created milieu that as if it requires leadership requires only these skills, right? And with that kind of a fixed idea, what has happened is which basically the chances are that men will have some of those elements more than a woman does, and the elements of a leadership skill which women are stronger at, like multitasking, communication skills between people, all these probably are not given as much importance as the ability to sit in judgment on top, right? So you need different forms of skills, and there are different formats of leadership which are there, and in the process what has happened is that many women are not put in leadership positions because they supposedly don't fit these kind of fixed ideas of what a leadership skill is.
And
yeah, I beg to little differ. I don't feel that in medical field there is a bias about the female leadership or a male leadership. Since I did my post graduation, I remember my head of the department was a female. Then I moved to different places, and in Max the CEO was the female. In Artemis, that time CEO was not the female, but currently there is a female CEO. So it is, I feel it's our created bias. Maybe in some other industry it could be possible that females are being sidelined because of being female, or gender bias is there, but in medical science I don't feel, and people are so mature. If the person is coming forward and working good, people become leader, and I'm sure you two are also facing the same thing. You are leader at your places.
Well, I would tend to disagree. There is evidence to suggest, and there is lots of evidence to suggest, that across even Europe and India, the entry point, we just had a discussion on gender biases that are there, and 50% of the students or 55% of the students who enter medicine are women now. But in leadership positions and specialization and leadership positions, the number of women is much less, much less. And that is what is, and there is evidence to suggest that there are certain kinds of biases at workplace. It is not an obvious discrimination of an individual that causes that bias. It's not that there is this hateful boss who controls. It is not like that. It is to do with the milieu that is created. That even, I mean, for hiring, right? Many places, I'm not saying that your hospital, but otherwise, that okay, you know, woman, or if they are pregnant, that you have to give maternity leave, etc. All these subconsciously play, and women's careers are affected by these things. It has been well documented, and even in places which are much more gender equal than India, in other ways, in medicine, there are published studies in NEJM, in internal annals of internal medicine and others, JAMA, which has shown that there are these biases, and how to go about changing that.
So I think we are not
I-
here to discuss
yes,
the
yes.
gender parity in the leadership.
Also, it's an
yes,
important factor which we should do actually.
So
Yeah.
Yeah.
let's come out of it.
Yeah. So I think we should stop here for the day. We will have a
Yeah.
whole topic of
Yeah.
Right.
discussion here.
Sure.
And let us not forget the president who will take over for ISCCM is going to be the first woman president. So women, yes, women leadership is definitely, there is a bias. I would not say it's just a perception. It is definitely, there is some amount of bias which does exist. So coming back to the human resource management again, I have a question which of course, which I face often, is they say that in your team, your team is the strongest, as strong as the weakest link in your team. So how do you really deal with that weakest link that you have in your team?
So the true leader should know the strength and weakness of their team. Unless you know the weakness and the strength of your team, not only the team, the individual person, you cannot take them along with. And what I feel, my perception is, I always support person who is the weak, but side by side I promote that person who is strong in that area. So rather than taking everybody to that level, it is much better that we should identify the strong suits and weak suits of each individual, and the weakest part could be supported by other team members who is strong in that suit, and the person who is strong in the other suit should be taken forward to that area.
So here I would also want to say one more thing, that when it comes to decision making, okay, they also say that when a leader is making all the decisions, he or she is actually leading a lazy and inefficient team. But in medicine, we often talk of, taking the right decisions, a single leader. So how do you really want to take with
So
that?
my opinion is little different. Whenever there is a, there is a dilemma, then we always sit together. The senior leadership in my team, we sit together, we discuss with each other, and then finally, of course, leader has to take the burden to carry forward that decision. But it's and you can appreciate that in a team member, if there is a 5 members in senior leadership, the opinion may be different of the 5 people, because everybody's experience, everybody's training is different, everybody's perception is different. So if everybody is having the same type of perception or same decision, then it means there is, without criticism, nothing can happen. So progress cannot happen. But the true leader is who can carry over all those people, who can take the opinion of all of them, and then can have a middle path or a better path which he suited. Sometimes it happens that 3 people or 4 majority is not in the favor of that decision, but still leader takes that decision and everybody abides by that. The second part is more important, that the team members should have faith in the leader, and they should have this faith that even we are not agreeing to this decision, but whatever he is doing is this because of the betterment, he is looking at the betterment of the team.
Yep. So I totally agree with him that it cannot be a total democracy, because medicine not being an absolute exact science, there are different ways to approach one single problem. But having said that, too many ideas at the same time can equally be deleterious for the patient well-being. So what one should is, the leader has to take which is the best approach, which is most amenable or favorable for the patient. At the same time, for those people who have been disagreed with, also need to understand that this decision has been taken with certain thought process in mind, which can be communicated with that person in the future, and they will also be reassured that whatever decision has been taken, maybe not this time has been followed, but maybe in the future, in next some other circumstances come up, then they will be having an equal amount of hearing. It's not as if we are going to totally negate them or ignore them forever. So that kind of feedback which people usually get that once their decision has been overruled by somebody, the grudge which people tend to bear, that needs to be smoothened out, and that's a part of the communication skill which is expected from a leader to work on.
Okay, Dr. Sumit, what do you think are the facilitators or the barriers in leadership? Both. Let us discuss both.
I mean, facilitators in the sense of for the individual or for the milieu?
For leadership.
The facilitators for being a leader, right?
Yes,
okay.
Yeah.
Okay. So to be a leader, I think, the facilitators would be that learning better skills of communication. Communication, right, is an exceptionally important part. And to understand communication, I personally believe, and different people would, I'm sure, have different viewpoints on this, is that understanding society is very important. And to understand society, you have to go beyond your medical, biological textbooks, I think. Learning other things, cultural things, socio-cultural things, to understand people, you need to know these much more to be able to communicate better. So reading about or learning about things which are outside just pure biological science, as I keep quoting Rudolf Virchow from the Virchow triad, he said, medicine is as much a social science as a biological science. So learning about society is as important for medicine itself and for leadership to be. So that is the facilitating part of what builds up the leadership qualities. And you said, what are the what do you say? Barriers. Barriers to a leadership is in the person. In the person is an inability to take criticism. We should be magnanimous enough to take criticism. Also the fact that also the reflexivity. As a leader, you should go back home. If not every day, once a week, you should think back what I could have done better for the department, for the individuals that I'm dealing with the patients that I'm dealing with, and have a larger vision of where you want to take patient care or your department in multiple ways. So reflexivity, reflecting on what we do is exceptionally important, because if we keep convincing ourselves that we are doing the right thing, that's not possible. No human being can do that. So reflexivity is a very, very important factor that we have to think of.
Dr. Koval, you want to add something regarding this?
Yeah, so whatever Dr. Kar has said, I agree with that, but there are certain things beyond that as well. The biggest, what I would say, the motivation to become a leader is a good boss, good leader. Working under a good leader, the good leader is who makes leader rather than leading the team, who supports others to become leader. And if the person is there, good mentor is there, who is grooming a person to become a leader, path becomes little easy sometime. And biggest deterrent is to have a bad boss sometime. If your boss is too bossy, too much dominant, then people sometimes tend to forget the leadership. This I am talking about in the workplace leadership, but certainly the leadership is not only at the workplace, certainly leadership is beyond the workplace as well. That's how one person leads his life. That is the leadership.
Absolutely well said. You should be a leader where people would want to follow you, and you have to lead with that passion. So there are definitely a lot of behavioral things that come into play, and I would want Dr. Shrikant to highlight on that aspect about that.
So quite a few aspects have already been covered about what behavioral attributes are expected from a leader. First is a good communicator. As he said, that is the key for understanding, to communicate your thoughts and to inspire the people who are a part of your team. Second is to understand, have empathy towards your team members. You should understand where they're coming from, what are the skills that they have. Try to always be positive in your, even if you're criticizing, you are having a positive kind of criticism. You're not really trying to pull them down. Rather, you're trying to make them understand in a positive kind of a reinforcement. Delegate responsibilities to others. It's not as if that you would take all the decisions by yourself. You would want to delegate. You want to empower your team members so that they also feel a sense of responsibility to complete that specific task which has been allotted to them, and give them a positive feedback regarding how they have been performing in the tasks. So these are a few things: empathy, understanding, communication, delegation of responsibility. So these are the few basic skills which one needs to, behavioral skills which you develop, and most importantly the ability to take criticism. So that is one thing which is there. People of the team may differ with you in a lot of things. Things may become, if you allow it to progress, things may become literally heated in the discussion, because everybody wants to do their best. After all, and when you are talking about a life of a person, everybody wants to do the best. Each one is giving their inputs, trying to do the best. So the ability to take criticism from the team and do it in such a way that it's constructive rather than being destructive. So that is the way we should take, and never try to pull down any team member. Whatever suggestions they may be giving, maybe it's out of sync with the current situation, but still try to place it in such a way that no feelings are sort of troubled. But at the same time, one has to be firm, that cannot be just allow things to go as per anybody's whims or fancies, and ultimately some firm decisions have to be taken. Sometimes decision may not be very popular with the rest of the team members, but such things have to be taken. At the same time, it has to be made to realize why these decisions have been taken, so that everybody looks up to the decisions rather than say that I was been overruled or countermanded for that reason.
Perfectly said, Dr. Shrikant. So we need to have a positive behavior. Dr. Sumit, what do you think about leadership in crisis? When we are in crisis, can we keep up with that positive behavior?
Right. And that's the biggest challenge to leadership, is leading in crisis. And as we all saw in critical care during COVID, so leading from the front in a when there is a crisis is of absolute essence, I think. And people look up to you if you are the one who is taking the risk and the responsibility in the matter of when it's a, it's a critical situation in every way. So leader, I mean, that is the making or breaking of a leader, actually, a crisis. If you cannot lead during crisis, the respect that your team has for you drops dramatically, and then it will become very difficult for you to lead ever really well.
So yes, the ability to take responsibility and not fix the blame onto others. Since you are the captain of the ship, you have to assume responsibility for whatever goes right or wrong. Eventually, the decision comes down to you. So even if a team member has taken a wrong decision, you should have the magnanimity enough to accept it as a part of the team. Trying to brush off the blame onto other team members would be very, very unfair to the team member, and would be actually a negative way of progressing with things, and will sort of definitely lead to loss of respect among your team members.
So there's a lot we can actually discuss on this, and do here that you all are actually great leaders, and you all have proven it by example. But do you have some outcomes or some benchmarks that you set for your own self, and what is it that you really look forward when you start your day, that you would probably set this as an outcome measure or a benchmark? Because that is what we do in critical care. We look at the outcome measure, and then we modify our scenario that way, or our case, or our treatment that way. So how do you look at yourself on your daily basis? I would just want each of you to comment.
Govil sir.
Yeah, this is a tough question. To be honest with you, I never set any goals for me. I never think about the outcome. I do it how it comes. That's it.
So similar here, you can't set actually goals for the day, that this is what I'm planning to do, this is what I'm planning to do, and not. But yes, every day you strive to improve yourself to a level where you are a good leader, but at the same time, you can't please everybody every day. That is something which one has to accept. One has to accept the fact that you can't please the entire team at all times. So once you have that understanding, then your goals become much more clearer. Your goals are for betterment of the team and for the betterment of the quality of care which you're trying to give to the institute or to the patient. So you really can't be pleasing or a crowd pleaser. That is not a part of that's a part of being a good leader, but one can't do that all the time, because the minute you stop pleasing, then you become a bad leader.
Yeah.
So that's the general human behavior. The more you start giving, the more you raise your bar, the more difficult it is to keep above the bar. At some stage, you're going to fall back from the top to the bottom and become the villain for everybody. So it's best to remain in the middle path, where you are having a fair and a balanced approach, where you are taking few hard decisions by yourself, at the same time sort of respecting their calls and decisions as well, and not try to overstretch. Know your own limitations, not try to overstretch yourself or bend yourself backwards to be an exceptional leader. That people don't, after a certain stage, that really doesn't work. So that's what I have understood with whatever experience I've had.
So I don't put daily targets, but yes, as I said, reflexivity being part of what one possibly does as a leader. So maybe once or twice a month, I think through what we have set a vision for the department in certain ways, my own vision of what I had thought, and what the rest of the team thinks of their vision of what it should be, and the balance between these, and what we have been which have we been able to take that path that we are heading towards that. Suppose I'm just saying that we have done intensive clinical work, some amount of academic work. The next target is research and taking the vision to a certain level of research. I'm just giving an example. So the rest of the team, some may be more enthusiastic, some less, and I reflect upon the fact that have we been able to take that path. The other thing I surely reflect upon, and the targets that I look at, is that in the process of leading, I don't push too hard, because that is the worst you can do. If you push too hard, you will have people falling away from you. So that's also sometimes something I look at every few days kind of thing, because I have a tendency to sometimes push too hard.
Absolutely. And all of you have been great leaders, and you have actually led by example, Radha. You want to say something, sir?
Yeah, so I just wanted to add two things which I think is still missing out of all this discussion. One is that whatever, if you feel that as a leader something went wrong, the entire team should do the introspection rather than putting responsibility and blame. That is also not good, to take all the responsibility on oneself, that say that I am responsible for this shortcoming and whatever it is. So at that time you can be a face, you can take all the shortcomings or responsibility on you, but later on we should together sit with the team and introspect. Each and every member should introspect that how we could have done better in this situation, so that in next time that situation may not arise.
It's very well put.
That is the one thing. Another thing is, leader should always identify the strength, and leader should push every team member to go beyond that strength every time. Like as Dr. Shrikant has said, that keeping a bar is and becomes difficult because you keep bar this today, and tomorrow everybody will expect this. True leader is who is keeping bar above with all the team members, so that in future, out of 1 year or 2 year, the team member will become another leader, because you have raised his bar from maybe 10 to 20, and he is achieving constantly. So many people are those who are born leaders, they need not to be pushed that much, but many people are not that, having not that good capability, so they need to be pushed. At that phase of time they maybe feel that they are being pressurized, but in a long run you will find that very many leaders will come out because you are pushing them regularly.
Absolutely, sir. Here is where actually the leadership role of debriefing and feedback and team positive construction of the team comes in play, and it is very well worded. And as I said, you all have always led by examples, and we look up to all of you all. And it is definitely tough to be a leader in critical care, because not only managing the team, you need clinical management, you need research management, and if we continue talking, probably any time would be insufficient. I would want to conclude it here, and I really feel that it's a tough job with having physical aspects to manage, emotional aspect to manage, and also self-introspect on a daily basis, how you can improve yourself on a leadership basis. So I would just conclude here, and I thank all the panelists here, Dr. Govil, Dr. Sumitre, and Dr. Shrikant, and of course my co-host Dr. Kaval Sodhi, and I'm Dr. Gunjan, and thank you for being a part of this. Thank you.
Thank you.
Thank you very much. Thank you.
Hello.
Hello.
One. Goal. Yes.
Goal. Testing 1 2 1 2.
1 2 1 2 1 2. All right.
I don't know this person, but
Hello. Hello.
Hello. Good afternoon, everyone. We are going to discuss about collaborations of different societies. We all know world is one. We believe in Vasudhaiv Kutumbakam, which means the world is a single home. So I'll start the discussion with Dr. Mishra. Why do you think Indian Society of Critical Care Medicine should collaborate with other societies? What do we gain? What do they gain?
So, not only Indian Society of Critical Care Medicine, but all the world society, they need at least one thing very important is the exchange of knowledge. There are certain things which we have expertise, there are certain things which others have expertise. Like say for example, very common problem, some of the toxicology, some of the trauma patient, or some of the tropical diseases which is very common in Indian content or tropical countries may not be in other part of the world. Apart from that, every society is growing in different pace with their catering to their local need. But as if some problem happens, maybe like pandemics, or some problem happens where it's a local problem, there also you need to collaborate. So you need to collaborate for pandemics like condition which can be a future problem. You need to have something disaster like you have a Turkey earthquake where also you need to collaborate. So if everybody is collaborated, then your strength and power increases. If you are single-handed, then when you need help, you may not get help exactly what you need at right time. So collaboration is the way to go ahead to become bigger and biggest.
Very rightly said. So we enhance our powers, we share our responsibilities while we collaborate. Dewell, what do you think COVID taught us? Did it fast track the inter-societal cooperation, inter-country cooperation? Did we learn our lessons about cooperation after COVID, right? And are we able to apply those lessons after 3 years of COVID?
thank you very much for this question. Very important questions. I think COVID taught us a lot in many ways. The way we organize our ICUs, the way the lay public looks at us, but also in the way we collaborate. And well, in the European Society of Intensive Care Medicine, per se, we are a regional society, and collaboration, as in the European Union itself, is one of the central themes, of course. Our membership also is partly from Europe, but 30% of our members come from beyond Europe, and this really also already shows that we have indeed a broader interest, that we have a broader reach. I think especially in terms of education, indeed, as was already mentioned, collaboration could be very fruitful, and the educational activities during the pandemic that were organized by the European Society, I think also demonstrate that. Also in our online pathways, our online learning activities, we have a lot of people from beyond Europe who are participating. And I think this really demonstrates how the world has become one place and societies are getting a more international or global reach.
George, I will put the next question to you. Does the cooperation should not extend beyond knowledge sharing? Should we not share our manpower? Shall we not share our skills? As Dr. Mishra pointed out towards the Turkey earthquake, we thought about that we will create a common workforce of intensivists, especially it was coming from ISCCM and other societies also. Are we able to achieve that? Well, thank you. Let me introduce myself. I'm Dr. Jorge Hidalgo. I'm the president-elect of the World Federation of Societies of Intensive Care and Critical Care. And your question is excellent. No? One of the important things of the collaboration is that the collaboration can go beyond just not only the sharing of knowledge, but also in situations like, just to put an example, with the earthquake, if we can have a coalition of trauma response among the countries, that is going to be should be a wonderful. It happened, but probably if we trying to strengthen that collaboration is going to be either much better. No? I think so. Ways of collaboration are a lot. It's just that, of course, different countries have different needs, and just trying to exactly see what is needed in my country probably is not required in your country. I mean, we need to see what are the ways how we can establish and strengthen that collaboration.
Very true. If we talk about clinical research, especially intensive care research, Dr. Mishra, I'll put this question to you. How is open source research methodology coming into picture with this global networking?
So let me tell you, explain both the fact. The global networking, you have to collaborate for different purpose, maybe for research, maybe for knowledge sharing, or maybe your experience sharing. As far as open research is concerned, every country has their own limitation to start research. If you ask me that starting randomized controlled trial, which is well structured in our country, it is very difficult, because as a clinician we have multiple tasks. We are still not that privileged. Okay, we can work for a few days and then we can do research for a few days. So our experience, whatever in management of case happens, and the way we improvise by learning by different media, if those those issues or those cases get accumulated, and if they can make a case series followed by a big source, a big data, that can even become individualized as well, that can even become precise as well, and that can help us in guiding better treatment. So when we share those data with the global research, although some may not be accepted, but if we start, today we are talking about the personalized and precise research, treatment. So when we are applying our clinical knowledge to be precise in the treatment, and if we can collaborate that data and start sharing a global network, probably it will help us in getting more data, because if we try to control everything with well structured randomized controlled trial, and we also know that everything is not that picture perfect what we imagine, so it may not happen. So we need to open up for different methodology, so get more data so we can become better. That's what my thought is.
Very rightly put. And we will probably have more representative data, we'll have more genomics group, because if a trial comes from, say, Europe, we always say the blacks or the Asians have not been included in those trials. So we'll distinctly have a more representative group and a more homogeneous group. Now we talk about shared manpower. While the COVID pandemic struck Italy and other parts of Europe, we discussed about how people who have been trained, say, with EDIC or other fellowship courses, they can cross the border and work in other countries. How well we are able to translate that thought into practice now? Deval, to you this question.
I think that's a very important challenge, and I can tell you that even within Europe it is a huge challenge to have people move from one country to another and their diploma actually recognized by the country people want to go and work in. So harmonizing all of this is very important, but this will be quite a big challenge, I think. Just based on our experience in Europe itself, it proves to be very difficult, and at this point even impossible to make this happen. And this free movement of intensivists is definitely one of the goals of the European society to facilitate and to make this happen. And I can imagine if it's a challenge to do this within Europe, of course, doing this on a global scale is yet another issue. But definitely as a concept, I think this is where we should evolve to, but not only sharing manpower, but also sharing education, sharing the different things an intensivist should do. We should agree on what actually the job exactly entails.
Very rightly put up. It's a challenge, and there are various challenges from medical councils and the laws which are prevailing in those countries. My next question will be for George. George, money is central to all the collaborations. We need to have partnerships which are financially feasible, and there should be some financial gains for the members, for the societies, and the intensivist community at large should also grow with such partnerships. What is your vision on financial challenges and financial plans for such partnership?
Well, that's a difficult question. Of course, back again to the question that you asked me before in terms of the resources and collaboration. Unfortunately, whatever is needed in my country, back again, the needs, the financial needs, the needs in terms of resources, in terms of manpower, the capability, the resources in terms of trying to also talk about standardization of competences, like to say, okay, I'm an intensivist and I also want to work in India, but what are the competences that you are required in India to be an intensivist? Probably are not the same, and then this effort of having us today is in a way a point to start. We are not going to solve this situation tomorrow, but at least we need to have a common ground and say, okay, we need to start right here in terms of competences, in terms of what are your society, how is going to benefit, and my society, how is going to benefit. At the end of the day, whatever we do needs to be a mutual beneficial relationship for parties, no?
Yeah.
To be successful.
Very rightly put. So it should be a win-win situation for both the partners. Obviously, some will gain on knowledge part, some will gain on skill part, but there should be some finances involved which should be making it financially feasible. I'll come to Dr. Mishra. Some societies, critical care societies, are very, very vibrant at World Federation, ISCCM, ISCCM, ISCCM. But some societies are not that vibrant and they live in shadow of others. We did some programs, ISCCM did some programs with neighboring Southeast Asian region, Bangladesh, Sri Lanka, and other countries. What is your vision to bring those societies up?
So it's like that. We have at present at large the 3 big societies in the world: SCCM, ESICM, ISCCM, and there is one collaboration of all societies, World Federation, and mostly I'm a representative of all 4 are sitting here. What happens, the bigger society, this should be one of the responsibility and vision of them to uplift those society. First we have to help them financially, like suppose we did program in Sri Lanka, we spend money from our own pocket, we went there, we taught them. Same thing when we did program in Bangladesh, we did of our own pocket. So what happened is, it's one of our responsibility to improve the knowledge, research and their skill. And if the bigger society start playing a more of role for the outreach, collaboration and helping, this will uplift them, and those society can become one of your big major workforce, particularly in the time of crisis when you need, particularly in those countries. So suppose you have trained hundreds of people in any of the country and something happened, like pandemic, we thought if ISCCM had not done this job, probably we would not have that many intensivists. So same thing can be applied, and it's very much possible that with the collaboration of all 4 bigger society, this can be planned and can be taken. It's not a very big task, and I don't think it even needs more money. It's very minuscule amount of money you need, and even at this time, even online training is very much possible. So we can do online training, we can do skill-based training, and all these things can be implemented. Even we can think for giving discount to those society members, like we did this time. We got members from Indonesia, we did not charge them, we have given them residence. We got members from Nepal, we got members from Bangladesh. So all these neighboring countries who are coming up, we have given them pre-registration, we have given them pre-stay, so they can come over, at least see what we are doing and improve their skill and knowledge.
Yes, Deval, please add on.
I fully agree. This is a very important aspect. Often I do think that it is probably linked to the development of intensive care medicine as a medical specialty in a certain country. And once it is recognized as a specialty and everybody understands what it is, then automatically a specialty and probably also a society may be able to grow. And for me, this is strongly linked to identity. Having an identity as a medical specialty, and intensive care medicine is a relatively new specialty. In some countries it's well developed, in other countries it's barely developed at all. And I think this is also a joint responsibility of the bigger societies to make this happen and to make people, to explain to people what intensive care medicine is, who intensivists are, who the specialized nurses who are working in our ICUs, what exactly that they do. We had a great opportunity during the pandemic to show it, but I think we're a bit losing this momentum to really make people understand the importance of intensive care medicine and the competences you need to work there.
George, you want to add on that?
Yes, I think so. The COVID-19 was a wonderful opportunity to open the doors to many instances of collaboration. Yash, you are an example of that. You help us, Rajesh, and many other members of the Indian Society. We have an opportunity to, I think so, I believe we did more than 250 webinars, and you guys were part of that, and also we have the opportunity to train more than 3,000 intensivists in Africa and some other low-income countries with the collaboration of many of you. And I think so, if that's, as Tiwal is saying, it's a momentum that we cannot lose. No, we need to, like right now, just strengthen the efforts and move forward and trying to look for other ways to collaborate and strengthen that effort. No?
Very rightly put. I'll go on to a very, very provocative question now. Resource limited settings. It is not necessary that third world countries or lower middle income countries are resource limited. We saw during COVID and various other crisis time that it depends on how much patient load you have. And at times, even in best of the centers in, say, US or European centers, we do not have a 24/7 intensivist coverage. We from India, Dr. Mishra himself also looks at some international ICUs for giving his expertise, especially in odd hours or a 24/7 hour, for improving their quality of care. So digital dimension of ICU care or tele-ICU is very, very important. And if we have trained manpower across the globe, our life will become easier. Maybe the cost of intensivist you hire for a tele-ICU in Europe is much, much higher than what we give a payout in India or in your country. So what is your take on adding digital dimension with this international collaboration?
Well, back again to what we mentioned already, COVID-19 was a good opportunity where we have and put in place telemedicine, and when it comes to limited or the resources, we need to differentiate in many aspects. You know, we talk about the human resources, we need to talk about equipment resources, and also we can also talk about the different areas of electronic records. Like in my country, that talking about Belize, the entire country is connected with an electronic records. It doesn't happen with our neighbor countries. No, I mean that it varies. It gives us a plus in terms of we have access, and if someone is referring a patient from even from the more remote area of the country, it's a connectivity, mean that, and if we can replicate that in some areas, talking about medical records, we talk about a lot of money, but now with COVID, we also know that certain technologies can be more affordable, and certain things can be more applicable. And back again to the competences. No, if of course if we going to hire an intensivist from the US or from Europe, in terms of what are the competences, and also how much are you going to pay for this type of services, I believe it's a huge difference.
Yeah. So financially, if we are able to share our resources, our expertise, probably we can cut down on cost and improve the patient outcomes drastically. My next question will be to Dr. Mishra. We talked about skill sharing, knowledge sharing, but we often fail to share our resources time and time again. And we understand, especially during crisis timing, resources are as important as human resources, the physical resources, might it be some drugs, antibiotics, oxygen, IV cannula, whatever. And we have seen during crisis in India like Kerala or other earthquakes, we have been pivotal, you have been driving of sharing of drugs to various parts of country. How do you think this collaboration, and during COVID time also we could share some remdesivir with our neighboring countries. Dr. Mishra, what plan do you have, what concrete plan do you have for research sharing?
Release resource sharing is not an easy job. Just say for example, I tell you, when there is economic crisis in Sri Lanka, we thought to share some medicine, and then I came to know that Indian government do not allow societies to share the spend money outside the country. So the one most important thing when we go out of the country, when we start sharing the resources, then the local laws come into place. Some laws may be there in Europe, some laws may be there in US countries. So how we can share the resource, we have to know. So when we plan to share the resource, first we have to understand the laws of the land, and once we have understood, we need to inculcate that plan in the society MOU, and based on those plan and understanding, so we have to come on to common ground, because these are the resources we can share, these are the resources we cannot share. But one thing is very sure, that this knowledge sharing really do not need any permission of anybody. Neither you need to travel, neither you need to go nowadays. You can share the knowledge even over the board at any time, just need to adjust some time. So rather than planning to share trained resources, we should plan to train people to generate their own indigenous resources. And if we can think in that direction, that will be best, because it's simply not possible to collaborate with the lawmaker, because lawmaker has a different perspective to think, and we as a society cannot fight those things. So I think that plan should not be there, rather than plan should be how I can improvise the resource, knowledge of the trained people. How we can train more people, how can we improve their knowledge, and how we can have more and more people. If we can do that, anytime that workforce will do a good job. Yes, if time comes, we get permit, we can definitely share those trained resources. But rather than that, I strongly believe I should focus on training people locally.
George, you want to add something on it?
Yes, on the resources sharing basically, because unfortunately, even if I want to donate this type of medication, I want to give you an idea. I have this tocilizumab, or I have this antibiotic that is needed in X country. The countries have their own regulation when terms of the importation of goods, medicine, and equipment. I mean, and even if we want to do that, we need to basically try to rely on what is the law for that country, and that sometimes is basically very difficult, mean that we need to look for channels when we're trying to share resources, medications, and see what are the appropriate channels for that. As Dr. Mishra said, in terms of the knowledge sharing, I think so that is there are no frontiers, no barriers. No.
You want to add something?
If there's one thing also what the pandemic learned us, I think, is that one of our most valuable resources are actually our nurses. Absolutely. Working at the bedside. And politicians often made a mistake. They were thinking, if we buy another 200 ICU beds and 200 monitors and 200 ventilators, then the problem is solved. This was absolutely, well, the opposite, of course. We came to realize now much more that ICU is about teamwork, and our biggest resource are the human resources. And it's certainly an aspect to consider when we think about sharing resources and sharing knowledge, and transferring this knowledge to other groups is, I think, very critical.
Thank you,
Thank you, everyone. Thank you.
At the end, I'd like to say we live in a single world. We need to share our resources for good of mankind. Thank you all.
And knowledge is the best resource.
Knowledge is the best resource.
Thank you. Thank you.
Thank you.
Thank you for the invitation.
Thank you.
Good afternoon, everyone. Building a research team in critical care is one of the key targets of our progress. So in this session, we have with us Dr. Ricard Ferrer, who is the head of ICU Barcelona and the treasurer of ISCCM, as well as the member secretary of the Council of the World Federation. Also, we have with us Dr. Andrew Conway. He is a clinician scientist in Cambridge NHS Trust Hospitals, and also holds the chair of ISCCM Infectious Disease Section. We have with us Professor G.C. Khilnani. He is now the head of the pulmonology division of PSRI Hospital, New Delhi, and he is also an ex-professor of AIIMS, New Delhi. Myself, Dr. Sulagna, and Dr. Sumit, we are going to interview our esteemed panelists today. So I start my question to Dr. Ricard. So, Dr. Ricard, when you start planning a research team, how do you begin? What are the key aspects that you cannot do without while building a research team?
Thank you for the nice introduction, and also thank you for this question. So I am happy to start. The first idea is that you have to have a clear idea which type of research you want to do. You want to do basic research or you want to do clinical research. I guess that for most of the intensivists it will be much more easy to start with clinical research, and especially with collaborative studies. So in a congress like that, you can have contacts, you can participate in the different working groups and to establish collaboration. And this is a nice way to start with collaborative clinical and maybe observational studies. So this can be the first idea. Second idea is that for sure you're going to need a research team. You cannot do this alone. You cannot do all the process of research alone, or you're going to need a research team that maybe at the beginning, when you don't have funds, will be a lot of voluntarism there, but you need to work with several people all together, trying to cover all the areas that we're going to discuss during this session. Also to look from collaboration to other groups in the hospital will be a good idea, because maybe you can share equipment, or you can share staff, you can share research staff, for example, or you can share an electronic database, for example. So I think searching for collaborations, I think it's an important thing. And also, of course, education, it's important to have a background in research and to train your teams in research. It's important not only in how to design a trial, how to analyze the data, also in regulations, ethics, and procedures. I think it's also very important at the moment we are starting.
Dr. Khilnani, would you like to add something to that, sir?
Of course, every country, every system, every regulations are different. In India, especially if I talk about critical care, doing research is not so easy. Reason being that small ICUs are there. So first and foremost, if you want to have any meaningful research and outcome, it has to be multicentric. Single-centric study generally would not give you sufficient number of patients to come out with a meaningful outcome. If I talk about the team, first it depends upon the research question. And if I talk about 30 years back or 40 years back, when I started my career, you could pick up any subject and start collecting data. Nobody was objecting. But nowadays, there are ethical issues, there are regulatory bodies which are there. So you have to have a proper research question, a proper format, and also it has to go through the regulatory body. Every research has to be registered with the ICMR, otherwise it will not have any value. Similarly, every research has to go through ethical committee also. So therefore, the planning is important. As far as the team is concerned, you need first, after the research question, you need a research staff. And besides that, you always need a statistician even before the research is started. when you conceive a when we conceive a research and the issue comes up, I always have a statistician with me who would actually tell me what should be the sample size, how many patients would be required, what should be the parameters, and what is the likely outcome and how much time. Secondly is the duration of the study. That's really very important. Generally in my experience what I've seen that you plan for 2 years and it goes on increasing. Third thing is the funding. As far as India is concerned, the Indian Council of Medical Research is the biggest funding agency, and it has it goes through a very rigorous process. So if I could summarize it, and unfortunately I must say that this takes about minimum 1 year for all these processes. But as far as the research team is concerned, there should be a research question, there should be a research staff, there has to be a computer operator, which you always require for feeding in data.
A data entry operator.
Data entry operator. And then a statistician who should be available for analyzing the data. As far as the collection of data is concerned, you need a dedicated staff who should be involved only for the research. Generally, what studies we conduct as a part of thesis or whatever, where the person is doing clinical work also and then collecting data also, that does not, in my experience, come out to be brings out a meaningful research.
So Dr. Conway, you have great experience in research. So this is the basic that we initially spoke about, the basic needs and the infrastructure and the personnel that we need to. How do you take it to the next level of research? What would you need to take it to the next level? What kind would be a next level of research in critical care, you would think?
So I think obviously when you're just starting, and I think as Ricard said, you need enthusiasm, you need to get your colleagues on board, and often that work is being done on a voluntary basis. Right. And there's perhaps not much in the way of tangible reward beyond feeling good about doing research, which is important. But I think when you want to take it on to the next level and start perhaps running studies yourself in your hospital, which then may move to other hospitals, rather than just collaborating on other people's studies, it's about having that infrastructure there. So you need to have a team of people, and different countries will do it in different ways. So some places will rely on research nurses to do a lot of that work, others will have clinical research practitioners. I think the key thing is that they have, that's their job. It's their dedicated job. They're not doing it as a hobby, they're not doing it on the side. And the sort of success breeds success. So once you've demonstrated that you can recruit into studies, then other people will come to you, either companies for commercial work or colleagues with non-commercial studies, will come to you and say, great, well, you recruited last time, so you can recruit again, and we'll give you some more money, some more funding, and you can then expand your team. And the challenge of trying to run a research team once you get to that stage is then trying to keep that money coming in so that people have some security of employment. Because it's very difficult if you employ people on a study-by-study basis, and then they're there, and then the money runs out, and then they still need jobs. They still have to pay their mortgage and feed and so forth. And so if there isn't money coming, then they'll go off and either work for somebody else or go and do a different job. So keeping that money coming is one of the challenges of moving on to the next level.
Dr. Ferrer, adding to that, do you think that the pressure to generate money can raise conflicts of interest, significant conflicts of interest?
Of course, because we have this pressure, but I think it's very important that to reinvest this money. This is very important. So the money you dedicated to make your team bigger, the money you dedicated to have administrative staff just for research, and you can be dedicated to raise more funds. This is very productive. The money you dedicated for research nurses or for study coordinators, or very important for project managers, because sometimes you are managing a lot of projects and you forget about the deadlines, you forget about the tasks you have to do, and you need somebody who organizes that. So the team is getting bigger, but because you reinvest and you don't use the money for other purposes. So I think it's important at the end, maybe when you finish that, you have your team in place, maybe you can use this money for other tasks, not for reinvesting in your team. But I think this is very important.
Right. Thank you.
So my next question to Dr. Ricard and Dr. Andrew is, what are the main hurdles that you have faced while building a team, and what do you expect to encounter in your present setup? What do you expect to overcome, and what challenges do you expect in your present setup to build a team?
If I may start, I will start with one point, and then we can share other points. But for me, the main concern is recruitment. Recruitment especially after COVID times is
patient
recruitment. Recruitment of the staff, especially after COVID times, to find nurses that want to be dedicated for research and not for clinical practice. At least in my setting, it's almost impossible. To have specific professional profiles, like for the ICU, I think data scientists are very important. We are generating data all the time with other devices that are monitoring or supporting the patients. All this data can be collected and can be used for research, but we need data scientists. In my hospital, we cannot hire because we don't have this profile in the list of professionals we can hire.
Right.
So we have to, if we want to have these professionals, we have to use funds for research, but we are competing with the big companies that are managing data. So I cannot compete with my salary from research for hiring a data scientist with, maybe the office of Google in Barcelona. It's not possible. So for me, recruiting of staff is the main one. Major one.
No, and I would agree entirely. I think in the UK that we have a similar challenge, especially post-COVID, with nursing staffing. And a lot of our nurses have moved on to do other things. And those who are remaining don't have the time. So sometimes we would ask them to come and help out or do a secondment with us. And they don't have the time. We don't have the flexibility to do that. The other thing I would say, the other challenge that we have is in critical care specifically, is competing with other specialties for research resources. So oncology and cardiovascular disease have much bigger resource, and again, it's the success breeds success. So of course, they do their big studies, and oncology has revolutionized itself. Even the 20 years I've been practicing, it's undergone massive change, and to take nothing away from them, but they do hoover up a lot of resource. And so trying to persuade funding bodies, and in the UK, the National Institute for Health Research, which funds a lot of our research infrastructure, to invest in critical care is a real challenge. And people often are quite fatalistic about critical care. They say, oh, all your patients die, none of your treatments work, and it doesn't help that we keep on producing trials in which the same, Kaplan-Meier curves come together. But so I think as critical care physicians and researchers, we have to go out there and make the case for critical care research and say why it's important and why people need to invest. And I mean, at the moment, that should be an easy case to make, because you just say, COVID, dexamethasone, tocilizumab. It shows what you can do with critical care research. If you put the time and energy and effort into it. You can get fantastic, world-changing results. And we have to fly that flag and say, come and do it with us, and don't give all the money to the oncologists. They can have some money, but not all.
Very well put, very well put. So, Dr. Khilnani, obviously the level of research and the challenges that they face in Europe is very different from what we face. What do you think are the biggest challenges probably in India for critical care research at this present moment?
If I talk about the overall research, the funds allocated by the government are not too many. They are, because I have worked in All India Institute of Medical Sciences and had number of research projects funded by the government.
I forgot. I thought
that is one. Another challenge is that you need research staff to conduct studies, and these research staff take it as a stopgap jobs. They have no future. If they work in the research project for 3 years, they are out of job. This does not give them any credibility. With the result that you have one person working with you for 6 months, then he finds another better job. Their salaries are not too good. More than salaries, there is no career path for those research. They don't get any importance of having done research. So there is so much of change in there. That's one of the big problems that in my projects got all the time. Besides that, of course, India is a populous country. We have, the finding subjects for research is not a problem. The ethics committees are well laid down. The norms are well laid down. Mainly, I think, is the amount of funding, rapidity with which we get funding, because it sometimes takes 1 year, 2 years to get a project funded. By then, I'm not talking about industry driven.
Yeah, of course.
I'm talking about the government funding
Public
the
funded.
funded project. And by 2 years, sometime the issue is,
Already too
becomes
late. Already too late, yeah.
unimportant.
Yeah.
But I'm not talking about the limitations only, but the thing is that population is big. We have a good number of subjects to work on. So if we could have more funds and more value for research,
Yes, definitely.
value means the person who conducts research gets enhancement, not in terms of money, in terms of career path. That should involve the research workers also. That has been sadly lacking, unfortunately.
So the
If
motivation.
that can be done.
The motivation.
Motivation in terms of career. If somebody has done a research job for 5 years, he should get credit in getting a better job.
Yes,
then only he'll continue for that length of time. Thank you.
So, Dr. Conway, back to you again. Do you consider diversity and inclusiveness while building a team? Is it important?
Oh, absolutely essential. I think the problem is sometimes it becomes a bit of a sort of tick box thing. You say, oh yes, we all subscribe to diversity and inclusion. We need to think why it's important. And it's because if everybody is the same, then we all just have the same ideas. Yeah, so we all sit there and we agree with each other, and suddenly you find yourself, I don't know, invading Iraq or something like that. You need diversity of opinions because you need somebody there to bring a different view. And I think diversity obviously can be experienced across a whole different range of situations. So there's obviously sort of, gender diversity, gender balance. I think that's really important. And particularly at hierarchies in the team, because it can be, still quite sort of male dominated at the top of the team, and the bottom of the team is quite female dominated.
Right.
So we have to work on that. And I think, your team needs to reflect the patients who they're looking after, because that makes them much more, especially when you're dealing with families in a very stressful situation. If you've got someone who understands where the family is coming from, I think you're much more likely to engage with them and agree to take part in research than somebody who you feel really quite different from. So I think, important that the team reflects the community in which it exists. But the other diversity we need to think about is diversity of professional background. So obviously doctors are involved in research, nurses are involved in research, but we also need to think about the associated health professionals. So in my department we have a pharmacist who's very interested in research and is very keen on developing the research sort of interests of the pharmacy team, dietitians, physiotherapists. So I think we need to look at the diversity of people out there, because again, physiotherapists have got different research questions from what I as an intensivist have, and my pharmacist colleague has different questions, and I sometimes struggle to I understand the question, but I struggle to support him because it's not my area. So what we need again is about building that capacity so that we have people at senior positions who are able to provide that thing. So it's across the board. Diversity is important, and we've got to include as many people as we can to make successful research.
Anything you would like to add, Dr. Ferrer?
No, I fully agree. I think those topics are very important. I think also that the grants and also the awards from the society are trying to help in that, to give visibility to this gender balance, and to also to promote the young investigators, and also the society. Our society have the next program, which is also trying to help junior intensivists to go also for research, and to give visibility that not only they do the research, that they have space in the Congress for also for explaining the research and the results of their studies. I think this is very, very important.
In the Indian context, sir, would you like to add anything to inclusivity and diversity of the researchers the research team that we build? And is it important?
No, it's not different from what they said actually.
So,
But
do you have any opinion on how should the ratio of clinicians and researchers, I mean, non-clinician researchers be, or what is your experience while conducting a trial based on maybe lab parameters, clinical as well as laboratory outcomes? So whether a team conducting such trials, a research team, will be different from those conducting primarily clinical outcomes. So maybe do we need to specify along the lines of research?
I mean, I think the team has to reflect the research that it's being asked to do. So if you are doing predominantly biological research, which is the sort of work that I mostly do, then I maybe need a little bit of clinical input to help identify patients. But mostly what I need is people in the laboratory who are skilled, who can do the assays that are needed to be done. And that's often in the form of PhD students and people from a scientific sort of biological sciences background rather than a clinical sciences background. But if I'm doing a clinical study, then I don't want scientists there pretending. So you don't want people from either side sort of pretending to have skills and experience that they don't have. It's about building the right team. So it's I think exactly back to the starting point. It's about that initial question. It's about what study you're going to do, and then you build your team appropriate for that study. And again, it's the success breeds success. So if you're doing biological work and it's working and you're getting the work published and so forth, then odds on you'll find more biological work to do. So your team has evolved in that way. Whereas if you're doing a lot of clinical work, then again, a lot of clinical research, then your team will build in a different way. Trying to straddle two different horses is really quite difficult.
That's true.
Yes, I said to my team that what they need is a good hypothesis. A good hypothesis is a good project. And as a head of the department and a head of the clinical research unit, I will provide the support by non-clinical researchers to go for this project. So this type of transversal support, so if somebody is taking care of the data, somebody is taking care of the administrative work, if somebody is taking care of the samples and frozen the samples and going to manipulate the samples, this type of transversal support is very important. If you can grant that to your team, and your team can think in hypotheses and try to design studies for answering these hypotheses, this is the way to go. When we are moving to multicentric studies, and we know each other very well, and I know that they don't have a professional team in place for doing the research, I know they will fail. They need this type of support, and of course at the beginning it's going to be voluntarism, but they have to do that. If not, it's really very difficult. So my task is try to provide this support to any of the clinicians that have ideas, hypotheses to be tested. And also very important, because we have a lot of time constraints, is how we organize the department to allow enough time for research.
Right.
If this should be done, or this is done in daily basis, so I mean I dedicated 2-3 hours to visit patients and then 2-3 hours for research, this is failing all the time.
Yes.
Because your clinical task is always priority.
Overwhelming.
It's usually are not very well organized and can be demanding in different times. So I prefer a structure of, and I think in UK you have a better organization for that, to provide a week for research or some specific time for research. Then you don't attend to the morning session, you don't attend to the patient discussion, you just go for your projects. But you have this week, and then this has to be accountable, and you have to report to the rest of your colleagues that have additional tasks because you are doing research, which is the final result.
So you wanted to add something?
Yeah, I just want to say, of course there could be clinical trials without laboratory, but there are very few. If I talk about progress in any part of medicine, be it critical care or be it tuberculosis, more often than not a laboratory backup is required. Now, if I would recall my experience at All India Institute of Medical Sciences, which fortunately gets liberal funding from the government, you may be running a lab without producing any money or anything.
Research.
And majority of the good papers came out when there were PhD students.
Yes.
So I come back to the same point that a person would work for a period of 5 years when he knows that at the end of the tunnel there is a light. You know, he gets a PhD degree or he gets a job, there is a career enhancement. So I am actually re-emphasizing what I said. To make a good research, of course, there has to be a big question. There has to be people from basic sciences. There has to be a statistician. There has to be a data entry operator. And time of expert should not be wasted in just collecting data. The data collection should be done by dedicated people, and all these people who are involved should have a career path or should have a permanent job, that their future is secured. Then only a meaningful research can be conducted with a good funding from some agency.
So my next question to Dr. Ferrer, Dr. Conway, and to Dr. Khilnani is, core research versus clinical research. How do you bridge the gap between skill and knowledge?
That's for you.
So, I think it is, again, as Rick was saying at the beginning, it's really important that you provide training for your team. And that there are, and again it comes back to what my colleague was saying here about the importance of a career development. You need to be able to provide that, and that comes, career development is more than just having a job and getting a pay rise. It's also about learning and gaining mastery in your area of expertise, where you then feel that you have something that is yours, that you can provide. So, for instance, you might start with somebody as a research nurse who's starting at a very sort of entry level, but over time is learning the skills that are required to run studies, to organise studies, to the point where they then become the kind of study lead manager and are then delivering those studies. And you've got to make sure that people in those positions are being educated, that you're supporting them with that they're getting the opportunities, that they're getting opportunities to come to congresses like this. Again, we've got to make sure that our research staff aren't excluded from these sorts of meetings. And again, especially I think with the scientific and the technical side, the data scientists and so forth, they sometimes feel a bit sort of out of the loop. So it's about providing those opportunities, providing education, and that sort of mentorship, as well as trying to run the team in a managerial sense as well. So it's a big job.
Yes. Fair.
No, it's. I think it's much more easy for clinicians. It's not easy, but it's easy for clinicians. But for nurses, really, it's very complicated. So if they don't have affiliation with the university, it's very difficult that they can get time during the daily job for research education. So it's really is a challenge. And again, I think that this should be part of our CV, which is not easy because when you are working in a public hospital, sometimes it's the administration who decide which is the criteria for hiring one doctor or the other, and sometimes it's difficult to include research criteria in the selection of intensivists. So if you are really want to promote research, you should include that in the CVs, and also include it in your objective for the year.
So if I may, how do you set goals for your research team, the targets and the goals for the individual in the team and the whole team?
Very important part of the objective at the very beginning is that the studies should be finished. And finished is when the paper is published. There are many studies that are started and finished in an abstract in a congress, and the paper is not written. And this is, or the doctoral thesis is not read. And the first one is that everything you start should be finished. Maybe the paper will be published, in a low impact factor publication, but it's important to finish. After that, of course, we can discuss if we have an objective of several papers per year, one grant, etc. There are some indicators that can measure your productivity in terms of generation of funds, in generation of papers, etc. But at least for the junior ones, just finish your work.
Dr. Conway, for the individual, do you think that you could set targets for the individual? One is the targets for the whole team that we would, like that kind of this amount of grant, these kind of grants, etc. But for the individual, do you set targets in your team?
Yeah, and I think it's those targets will depend very much on what the person is doing. So a PhD student, it's really important, first thing is they have to finish their PhD and they have to get their thesis. They've got to have something to show for having spent 3 or 4 years with you. And then after that, yes, they should absolutely get papers out, because if they're not getting papers out, no one ever is going to read the thesis, even in these days of online thesis. Yes. Nobody ever reads them. So it's, but it's about setting objectives that are specific to that person. So perhaps for a research nurse, it's around, again, when they're starting, about taking on responsibility for a couple of studies, making sure that recruitment is good, making sure that we're hitting recruitment targets, and then also asking them what their objectives are. What do you want out of this? Where do you want to go with your career? And some will be saying, well, I would like to actually go on and do my own research and do a PhD and so forth, so it's about supporting them. Others would say, well, no, I'd rather develop managerial responsibility within the research team. And so you want to make objectives, specific to that person that are achievable. There's no point in setting goals they're never going to achieve. And then also holding them accountable. So you come back and you say, well, last year we said we were going to do this. But also holding yourself accountable. You say, last year we were going to do this. If it hasn't happened, why hasn't it happened? And is it something that we could have done better to support you? Or was it because, you couldn't be bothered?
Dr. Ferrer, you wanted to say something, add something?
Well, sometimes reporting your research is a very complex task. Depending on the agency is evaluating your research team, they ask how many studies do you have, or how many publications you have as senior author, as a leader author, as a first author. For example, some agencies are not considered collaborating studies. And now in intensive care, we're doing a lot of collaborative study. If I am doing a study with 20 ICUs in Europe, how I can be the first or the last author? Can be maybe one time between 20 studies, but I'm not going to be always the first or the last author. So it's, and you have to have again, just administrative staff, just for reporting every year what we need just to collect from our research foundation, for the funding agency, just to put all together in a single document. It's really time consuming.
It's a tedious task.
Dr. Khilnani, would you like to add something to that?
No,
yeah.
I'll put a different perspective of that, because I might have done hundreds of dissertations for PhD and MD students. Not even 10% lead to a publication. Besides my grudge against them, there's another aspect of it. When you force or coax, or you are able to make them write few papers, they learn, and they get addicted to writing papers, like you. So if we don't do that, then those people are away from research. So your pool of people who are interested in research goes down. So at the All India Institute, which has largest publication in this country, out of proportion to all, some of our students who write 4 or 5 papers in their 3 years' time, they continue to do that in their career. Some people, they finish their work and just go away. So it's the onus on us also, onus on us also to coax them to write before they leave because once they leave the course, they're gone. So probably I am deviating from little the subject, but if we want to promote research in the country or the society, then it is important to instigate or encourage younger people to do research and be in the habit of writing. And also it is onus is on the government or the institution to give importance to their writing work. There are universities which won't promote a person on a teaching side unless they have published n number of papers. And that's one way of promoting research in the biological sciences.
Thank you so much. So today we would like to end this discussion. We thank Dr. Ferrer, Dr. Conway and Dr. Khilnani for their valuable perspectives, inputs, and we wish that all our viewers, we all
will be able to form and progress with good research teams. As an African proverb says that if you want to go fast, go alone. But if you want to go far, you should go in a group. So a research team, a good research team, building a good team will help us to achieve our dreams in our research in critical care. Thank you.
Thank you so much.
Thank you.
Thank you.
Very much. It's a pleasure.